Okay, good morning, and thank you very much for inviting me to speak. Yes, I'm local. I'm glad that you were able to make it during the snowing morning, though last week we had 70 degrees and it was a beautiful spring. We will switch gears a little bit and I'll talk more about cells rather than stem cells. And as I was introduced, that my primary research is in post-traumatic osteoarthritis. I don't know how many orthopedic surgeons are here or people who are doing research on cartilage and connective tissue, but I hope that the talk will be of interest to the entire audience. So here just disclosures that the work which I'm going to present today has been funded by a number of industry and foundation as well as NIH and my endowed chair. And most that I'm doing in my laboratory is with human cadaveric cartilage from donors. It is a cartilage which we receive fresh within 24 hours of death, and it is normal by all the characterization. And one of the exclusion criteria is that donor had no documented history of joint disease. So we have a unique opportunity to use donor cartilage of all ages, all spectrum of normal preclinical pathological changes which have not been clinically diagnosed. So as many of you know that more than 12% of prevalence of severe osteoarthritis is attributable to post-traumatic arthritis in the hip, knee, or ankle joints. It is probably more than 6 million people just in the United States who have signs of post-traumatic osteoarthritis. And the problem is that patients who present post-traumatic osteoarthritis usually much younger than those who have idiopathic or degenerative osteoarthritis, which again brings a huge issue for treatment choices, and it is very expensive because it has huge impact on financial impact and many people with disabilities, which is presented at much earlier ages. It is even more serious problem in people who are involved in active sport and athletes, professional. As you can see, the prevalence is increased by almost more than 3 times, and there's a number of injuries which are associated or which can lead to post-traumatic osteoarthritis, and those are meniscus tear, ACL tear, or collateral ligament tear. And majority of these patients are symptomatic. If you compare the number of, if you look at the epidemiology of osteoarthritis, you can see that with more impactful sport, and impactful I mean more professional sport, the epidemiology of post-traumatic osteoarthritis is greatly increased, and it is 5 to 12-fold increased risk of athletes to develop severe post-traumatic osteoarthritis. So what is the problem? The problem is that cartilage is one of the connective tissue, or one of the musculoskeletal tissue with the lowest ability to repair or regenerate. It has, as you may know, that the structure of cartilage, it has no blood supply, no lymph supply, no nerves, and that's why the supply of nutrients which would help to stimulate cartilage regeneration and repair is very limited, and it comes from external sources, and that represents one of the biggest problems in regenerative medicine and for cartilage repair. It's not the only problem when you think about cartilage repair. Cartilage is a very thin tissue. The thickness of cartilage in human joints varies from 2 millimeters in the ankle to up to 7 millimeters in patella. It has to resist compression. It has to have low coefficient of friction, and it should be able to distribute the load of the body weight, and it has to last for quite a long time. It is also important to remember that spontaneous repair fails to originate normal tissue, which means that it might also have problems with the host tissue, both the bone underneath or cartilage on the side. Furthermore, because of it doesn't have enough time to build the right structure, as if you take an example, newborn cartilage, and it has time to mature and develop zonal distribution to be able to withstand the load, regenerative cartilage does not have this time, and that represents more challenges for this either spontaneously repaired or regenerated cartilage, because not only the issue with the integration with the host tissues, but it becomes more susceptible to re-injury and to inflammatory environment which might be presented within the joint. So again, I hope that I convince you that to regenerate cartilage is a big issue and it's not an easy task. If we adopt the diamond model, which was developed for bone regeneration by the Department of Thomas Einhorn in Boston University, if you think about cartilage regeneration, factors that we have to consider, that underneath it should be able to integrate with the bone. It requires chondrogenic cells, whether it is stem cells, bone marrow cells, or it might need to have scaffold, not necessarily, but it may. It probably requires active agents which would stimulate matrix production, because cartilage is a very unique tissue. It has only 5% cells of its volume, and the rest is water and the extracellular matrix. Again, we were talking about mechanical environment, so it should have proper mechanical environment in order to build the right structure of the tissue. And on top, it has to face a novel environment, which might be hostile, it might be inflammatory, yet it most likely provides stem cells from synovium. It also might require chondrogenic scaffold and chondrogenic cells. So what are the treatment options nowadays for cartilage injury? Primarily those are surgical options. Debridement lavage, just to remove the fragments. Marrow stimulation, which is largely based on bone marrow stem cells, which are coming up to repair the cartilage. Osteochondral transfer technique, and those include both autograft and allograft. And there's a number of cell-based cartilage repair techniques which are widely used. Those are with use of autologous chondrocyte transplantation, which was discovered and characterized more than 20 years ago. There's another way of inducing cartilage repair by the use of characterized chondrocyte implantation, scaffold-associated chondrocyte implantation, and those are a number of different ones owned by different industry. Neocartilage transplantation, if people regenerate cartilage in vivo and then transplant the entire cartilage, and as well gene therapy and stem cells, when cells are either transfected with the genes of interest or stem cells are used for cartilage regeneration. And of course, there's a number of biologic ideas which are now part of the clinical trials, and I'll get back to that. And those include platelet-rich plasma, growth factors, caspase inhibitors, and others, and cartilage tissue engineering. There are some emerging experimental approaches for cartilage repair. Those are based on the use of periosteum cells or use of physical methods to stimulate matrix production. Those also can be cellular or acellular scaffolds, hydrogels with or without cells, because I don't think that there is a uniformity in opinion that you absolutely necessarily need to bring the cells. Maybe there's enough cells to come from the bone marrow and from synovium, and nanoparticle technology as well. There's a lot of new developments on the use of therapeutic based on vitamin D, growth factors, and I'll touch upon those for a little bit, and specific pathway targeted therapy. The list of those are here. So what I'm today, few studies that we have done in my laboratory, and those when we try to characterize chondrocytes used for autologous chondrocyte implantation, the methods which is introduced by Zimmer de novo using juvenile cartilage, osteochondral allografts. There's a new technology that we are very excited about, introduced to Hill company from Israel, and biologic approaches which we are widely using in my laboratory, trying to understand the mechanisms which drive cartilage regeneration in post-traumatic osteoarthritis. And those are experimental ones. So let's talk about autologous chondrocyte implantation. Probably all of you, or many of you, are familiar with this method when chondrocytes are taken from the normal cartilage, non-load bearing area, used for expansion, usually cultured for a couple of weeks, and then they transplanted back onto the periosteum into the defect in the joint. So what we did, we took these leftovers after the expansion, those which were just leftovers after surgery, and we wanted to understand the biology of these cells. So what we noted that, and usually chondrocytes are rounded cells, that's how they look in the monolayer cultures. As soon as we try to plate them and culture, they immediately change the phenotype, and they become more fibroblastic with elongated shape, which means that they would produce different matrices than primary chondrocytes. So we try to understand how these cells respond to stimulation with growth factors, as we always used in our models with primary cells. And what we found that with normal physiological doses of growth factors, whether it was osteogenic protein 1 or insulin-like growth factor, there was basically no response. These cells required larger doses or combination of these factors in order to produce at least proteoglycans, one of the major components of cartilage. We also found that if we put these cells in scaffold, they like it more. They do keep their phenotype, but without any stimulation, many of them are dying. So again, it seems that their survivorship is lower than primary chondrocytes. But when they're treated with these growth factors, they can expand and then they can perform quite okay. We went further. It's a busy slide, and I'll walk you through. So we looked at these scaffolds, and we wanted to see what kind of matrices these cells deposit, because it's very important to know that if you inject it into the patients, these cells deposit the right matrices. So here, this panel is normal chondrocytes, primary chondrocytes. You can see that under combination with growth factor, especially, they deposit well-defined collagen type 2 and aggregate matrices. While if you look at the same group in the ACI cells, you don't see as much matrices. You don't see this matrix to be deposited in these cells. They do respond to individual growth factors treatment, but much to lower extent, which suggests that these cells do have altered phenotype and their metabolic activity is changed compared to primary cells, which again brings the question how good this technique, and at least it can give us some ideas why in some patients there's failures which are noticed and documented. Another approach which is widely used by orthopedic surgeons is the use of allograft, osteochondral allografts, when the plaques of donors are inserted in the areas of the defect. Again, we wanted to look at these cells because we did hypothesize that when you impact or insert these plaques into the area of the defect, you subject these plaques to two big challenges. One, the impaction, like mechanical influence on the superficial layer of these cells. And these cells usually are inserted into kind of pro-inflammatory environment, which the injury from the joint. So we mimicked this idea in the lab, and what we found that here's the superficial data for superficial layer, and here for the entire cartilage. Red is osteochondral allograft, and black is fresh. So what we found that at the beginning, it seems that both have relatively similar viability, whether in the superficial layer or throughout the entire depth. But as soon as you add insertion, because that's how, or impaction, which mimics this insertion, you can see that the viability of the superficial cells drastically decreased. And it's primarily in the osteochondral allograft cells, because these plaques or these cartilages have been stored for at least 2 to 3 weeks. And you can see that these red cells, it is dead cells, and green ones are alive cells, and you can see that there is more dead cells as you subject these plaques not only to impaction, but also to the effect of inflammatory mediators, which be identified in synovial fluid of patients. So what it suggests to us that osteochondral allografts, and you can see these red lines all over this graph, that they have lower chondrocyte viability than original normal tissue, which again presents a challenge for appropriate cartilage repair. We looked at these plaques with safranin staining to see the structure of these cells and these cartilages, and we found that as soon as you put these osteochondral allograft sections into the culture, you can see the depletion of safranin staining, which again shows that there is a washout of major matrix components. And what is very striking and very disturbing that if plaques were stored for more than 3 weeks, you can see total change in the morphology of the tissue. Surface becomes smooshy and soft, which convinces me that it's very unlikely that this cartilage will do well in the joint. So if you summarize data for osteochondral allografts, it seems that this tissue is less viable and more susceptible to the influence of catabolic mediators, whether it is biomechanical load or cytokines, that the way these plaques are inserted is very critical because it may set the stage for allograft failure, and that if it's stored for a long time, it definitely presents a problem for cartilage regeneration. So let me show you the next technique. It's the novel technique developed by Zimmer, when they use juvenile cartilage minced into very, very tiny pieces. They put it in fibril glue and put in the area of the defect in patients. So what we find that, and we compared these cells with the dull chondrocytes that we get from donor cartilage, which is fresh. So what we find that you can probably see here, that cells migrate from tissue, outside of the tissue, both from juvenile cartilage as well as from adult cartilage. If you compare here, with the exception of the older donor who was 74 years old, the time of migration when cells are in culture and they start to migrate out of the tissue doesn't change or is not varied between juvenile or adult cartilage as long as it is within 50 years of age. You do see high metabolic activity in terms of gene expression in these de novo juvenile cells compared to adult cartilage. If you look histologically, you find that there's more matrices deposited by older cartilages or chondrocytes than by juvenile. So again, we didn't see that much difference between this preparation and adult cartilage or adult chondrocytes as long as they're within 50 years of age. And but we also found that there is no need to mince the cartilage into those tiny pieces because we use much larger pieces and we found similar results. So summarizing the novel, it is the prep itself is very heterogeneous, and its viability and migratory activity varies between specimens. High migration of de novo and adult chondrocytes was observed when high serum present and fibrin glue, which again may not necessarily be conditions when those cells are implanted into the patient. There is no difference in terms of the time when cells start to migrate, as long as it is within 50 years of age, and there is no significant advantages have been found in our lab in terms of use of de novo cartilage versus adult. So the next technique which I want to introduce to you, which we are very, very excited about, it is based on corals, modified coral. It is a company named CartiHeal, and they use this bifacial construct which has coral and on top hyaluronic acid, which is meant to be embedded into the osteochondral defects, cartilage defects. And the idea is that this bone face will attract MSCs from bone marrow cells, and the cartilage face will attract cells from the superficial layer of cartilage or from synovial fluid, synovium. And the company showed very encouraging data with 6 months follow-up and 12 months in the next slide, when cells which had this osteochondral construct or coral construct, cartilage regeneration and bone regeneration was much more apparent than those which did not have this construct. And you can see with a micro-CT that bone regeneration was quite appreciable versus a control which didn't have that one. So the question which we ask in the laboratory, what is the mechanism? How does it work? And whether human cells will respond similarly to the animal cells? Because experiments which I show, animal experiments were. So we prepared the cartilage explants in the shape of donuts, and we inserted the construct in the middle hole. So what we found that yes, cells do the tissue. You can see all these green cells which are migrating from the tissue. You can see that we were able to identify cells within the pores of the construct. And what is interesting, histologically, we can see that cells are migrating into the construct and they're depositing extracellular matrix. Our new data show, which I'm not going to present today, that many of those cells are stem cells or stem cells from superficial layer, which really doing the job for cartilage regeneration. Because in the control, when there is no cells also migrate, but they migrate from the deep layer and then immediately become hypertrophic, and they do not move as far and they do not deposit extracellular matrix. And we also found that in the presence of these coils, there is more production of proteoglycans in both knee and ankle joints, and which is important because it can be a number of different pathologies and a number of different joints. We always compare knee and ankle in our work, and these cells produce more aggregan and collagen than cells in the absence of the control. So again, summarizing this part, that it seems that it is a unique acellular scaffold which is capable of inducing regeneration, attracting cells from the bone marrow and from the synovium, that the tissue, regenerated tissue appears to resemble hyaline-like cartilage in both in animals and in human cells. There was no adverse effects noticed and noticeable, and there's the clinical trials which are using this construct now. And it also showed that it seems that this approach stimulates cartilage-specific gene production. And the people who are involved in this work truly believe that it might have strong evidence for clinical application. So now we are switching to post-traumatic osteoarthritis and trauma when trauma is inducing cartilage regeneration. So analyzing the work of multiple laboratories and using our model when we impact cartilage like a dashboard injury, we were able to characterize cellular response which specific for immediate cellular responses, which are specific for cartilage injury. And as you can see, that there's about 3 phases of these responses. Phase 1, or early phase, which is characterized by cell death, both necrosis and apoptosis, elevation of pro-inflammatory mediators because cells are damaged and all intracellular components are released. Then there is some initial anabolic response, which is characterized by elevation of growth factors, superficial zone protein. And then there is kind of an intermediate phase of equilibrium between catabolism and anabolism, and then a remodeling phase, which is more characterized by anabolic responses. So based on these data, we decided to use a number of different therapeutics to see whether we can use mechanism-based approach to arrest cartilage regeneration. And based on these data, there are 4 key principles for therapy which can be used. Chondroprotection, to protect cells from death, anti-inflammatory, matrix protection, and anabolism, to stimulate matrix production. So in terms of chondroprotection, I'll show you data with 2 different treatments. One is we used P188 surfactant. It's just a regular surfactant detergent, which is very cheap, $8, very like up to $10 for the prep. And what we did in this impaction model, what we found that if you impact the cartilage, of course cells die under the area which was subjected to the impaction. But what is more important, that even the areas which were not subjected to the impaction, but they're adjacent to the impaction area, cells start dying, regardless that they did not experience the impact, because those from the impact, they release cellular components which mitigate the cell death and expand cell death both horizontally and longitudinally. So when we applied this surfactant 1P188, we were able to arrest this spread of cell death both in the areas which were subjected to the impact, red line here, core, or in the areas which were adjacent and did not experience the impact. So at least we were able to show in the experimental approaches, both in the lab, and there were work on rabbits in other lab, which showed that yes, you can arrest cell death, and thus you can prevent cartilage, or at least reduce cartilage degeneration induced by trauma. In the laboratory of Iowa Orthopedics, Dr. Jody Buckwalter lab, they use reactive oxygen species antioxidants, rotenone in this case, to see whether they can arrest cell death and cartilage degeneration. And you can see here all red cells after impaction because of cell death, and when they used rotenone, cell death was drastically reduced. We also found that regardless what kind of mechanism you target, it is possible to arrest cell death. So this line is normal, here impacted, and everything colorful is different approaches that we tested. So all of them were able to, a certain degree, reduce cell death. So the next question is it sufficient? Because cell death is only step number 1, but is it sufficient in order to stimulate matrix production and reduce cartilage regeneration? So there's a number of growth factor families which has been considered for cartilage regeneration. I'm not going to go through all of them. I'll talk just about one, which was heavily studied in my laboratory for more than 20 years now. And this is bone morphogenetic protein 7 or osteogenic protein 1. And then I'll mention at the end what kind of clinical trials are now registered for cartilage regeneration. So what we found in our lab and in many labs throughout the country, that BMP7 is able to stimulate have a reparative effect in different models, both human and animals. Mosaic-plasty, osteochondral defect, chondral defect. It also has protective effect in models, as I just mentioned to you, ACL injury and acute trauma. And all the mechanisms of its effect have been characterized. It has anti-apoptotic effect. It has effect on stimulation of matrix synthesis, on inhibition of key pro-inflammatory mediators like MMP13 production and caspase inhibition. So it has a very wide, not only pro-anabolic, but anti-catabolic effect. In our trauma model with Dr. Herchik from Canada, we also found that within first week, if you apply BMP7 right at the time of injury, that we were able to, reduce apoptosis, we were able to protect more cartilage and to have a reduction in leukocytes. So in this particular case, BMP7 was injected at the time of injury and 1 week later. Is the effect sustainable? And what is the right timing for therapeutic application? We found that if the treatment is applied immediately or soon after injury, in this case 1 week, within 1 week, here 3 weeks later, and here 3 months later, you can see that 3 months later there was no effect. Growth factor was not able to arrest cartilage regeneration. Yet, when it was 3 weeks and specifically 1 week, it did have protective and regenerative effect. And the more point I'm trying to make that it's not only what kind of therapy, but the timing of therapy is absolutely crucial when you treat patients after trauma. So here's a list of clinical trials which aim to address different biologic approaches to cartilage repair. As I mentioned, de novo techniques, microfracture, which uses stem cells, autogenic stem cells. There's a number of studies with chondrocytes which are transfected with TGF-beta, another growth factor which is used for cartilage regeneration. Again, comparison of ACI and microfracture, neocartilage, again microfracture, platelet-rich plasma. There is more and more interest in plasma-rich plasma, in platelet-rich plasma, stem cell therapy, allografts, MSCs, matrix autologous chondrocyte, and FGF18, another growth factor which has been tested for osteoarthritis patient, and that clinical trial basically failed because in degenerative late-stage osteoarthritis, the growth factor FGF18 was not effective, and now it's a new trial which we haven't seen the data yet for post-traumatic osteoarthritis, when they really limited the age of patients and the pathology these patients present. So as you can see, it's not as much as one would expect therapies and therapeutic approaches to osteoarthritis, but basically it is cells, whether stem cells or different techniques to cartilage repair. So to summarize, what is the emerging therapeutic approaches for cartilage intervention in post-traumatic osteoarthritis. Mechanism-based to arrest cell death, to arrest apoptosis, antioxidants, again, targeting specific pathway. There are some natural products which are becoming more popular now, resveratrol, green tea, polyphenol, vitamin D, and others. There is matrix protection, again, to inhibit matrix metalloproteinases, so as a factor which can induce cartilage damage. And there's pathway-specific targeting opportunities, and anabolic, which is growth factor, small molecules, and platelet-rich plasma. Probably the most potent are those which have combination of different factors with different mode of action. And there's also on the market synthetic biolubricants which are going to be tested for cartilage repair. Again, as I mentioned, it's very critical, the mechanism, time, dose, target, and treatment regimens. And if you use biological molecules, it's always important to remember that chondrocytes produce these molecules. So in the assessment of doses, one needs to think how much endogenous growth factor or how much endogenous biological factor have been produced by chondrocytes. With that, I'll stop and thank you very much. And that's how Chicago looks at night without the snow.
We're going to have time maybe for one question in the interest of time.
Here you go, man, right here.
Thank you. I would like to ask, have you did a comparison between mesenchymal stem cell and chondrocyte autologous for clinical trial for chondros repair for cartilage?
We haven't done direct comparison. We don't work that much with MSCs, but there's a lot of literature on MSCs. Which, I mean, the data which show with MSC that cartilage which was generated or regenerated, it doesn't have the right structure. It has the same problems with integration, with the host tissue, sustainability, and being able to sustain the load. I mean, it all the same problems as I was talking about cartilage regenerated from different means. I haven't seen absolutely convincing data with MSCs that, yes, this cartilage looks perfect. And again, the question is whether it has to look perfect, whether even if it is fiber cartilage, but it can delay the time for surgical intervention, is it going to be good enough? And I don't think that we're ready to answer this question as well.
Okay, thank you.
I want to make a quick question. Okay, just one.
I was just wondering if maybe a tissue engineering approach for inducing the mechanotransduction and maybe selecting for cartilage that actually were more load-bearing is something that that you think might be the missing link in getting to the point where you get the proper kinds of cartilage production from MSCs.
You mean, I'm not sure that I understood what you meant with load-bearing versus non-load-bearing.
Right. So, I mean, you know how muscle tissue that's been reconstituted and reconstituted into tissue, in vitro approach has to be actually exercised in order to get it to develop into functional muscle tissue.
We tested chondrocytes from both load-bearing area and non-load-bearing area. As soon as you remove chondrocytes from matrix, they lose this spatial specificity. If you keep it as explants, you might, but again, when you transplant it into the joint, it's a whole different scenario. So once you start manipulating them in vitro, there's not much difference in terms of sensing biomechanical load and responses to biomechanical load.
Thank you.
Thank you. So our next speaker is going to be Dr. Dennis Lux. Dr. Lux is the Director of Sports and Regenerative Medicine Center at Stem Cell Center of Excellence in Washington, D.C. metro area and the Tampa Bay metro area. He attended the University of Arizona studying liberal art, and then he did his medical training at Texas Tech University, followed by his residency at the University of Texas Health Sciences Center in San Antonio. He has always pursued sport medicine. He's widely published, and he lectures nationally, internationally on sport regenerative medicine.
Thank you. We're loading the slide. post-traumatic model, and it's of great interest to me. Being in Florida, I have an elderly population, and I also have athletic population. So I've seen the similarity between arthritis in athletes and arthritis in the elderly. And the thing about athletes is you can use them as an accelerated model of arthritis because it happens in a very quick period because of the unique aspects that they put the stress on their joints. Some of the other reasons why this is, I think, very important and germane topic. Patients are interested in it. We have a lot of weekend warriors, and they want to continue to do their sport. Obviously, professional athletes are highly interested in continuing because of financial and also their personal reasons. That's who they are. But also, I have patients who come into me and they're looking for alternatives. They don't want a total knee replacement, and that's what's being offered to them. So they look for alternatives. I had a patient who has rheumatoid arthritis, and she said to me, well, how does stem cells or regenerative medicine work if I'm on Enbrel, if I'm on a TNF-alpha blocker? And that's a very interesting question. So I have a lot of sophisticated patients who do their research, and they actually want intelligent answers, so I'm going to try to present it in such a fashion. And then I get other patients who their orthopedic surgeon tells them there's no science behind this. One orthopedic surgeon told my patient last week that this is voodoo. So I hopefully will present some information that clarifies that. And when we look at some of the articles that are written from sports medicine model, you'll see that one writer last year said, we have a problem with stem cells. And the other is saying that this is cutting-edge treatment. When you understand tissue repair, we're just trying to heal these patients with whatever regenerative application we have. We cannot make a patient bionic. The best repair you can get is 100%, and generally we don't get 100%, but we're not trying to do anything artificial with this patient or doing anything elaborate, except for to try to promote tissue healing. So what's really the difference between sports medicine and osteoarthritis? When we look at athletes, and we see some very famous people, Joe Namath, Brett Favre, Bo Jackson, Peyton Manning. Peyton Manning is famous. He went off to Germany and had stem cells in his neck after he had a neck fusion. Well, what these athletes all want is they want to prolong their career and prevent, ultimately, arthritis and ending their career. Well, Joe Namath was very famous in that he ended up with bilateral total knee replacements. So the difference is really time. And if we can make a difference in time and deter or prolong the interval from them developing arthritis, then we've done our job. But that's exactly what most patients want, is they want quality of life, they want to deter arthritis, and they want to engage in a functional life as possible. So if time is the difference, this particular patient, if you look at his injury just from this model, he's really going to develop arthritis before he ever sees a sports medicine doctor. The trauma that's occurred there is instantaneous arthritis. These are two very famous athletes, Joe Namath and Denny McLain. In 1969, Joe Namath was the biggest name in football. He won the Super Bowl and was MVP. In 1968, Denny McLain was the MVP of the World Series for the Tigers. Joe Namath is very famous. Again, he had both knees replaced. His career was derailed early for constant knee problems because he had numerous surgeries, so he developed arthritis at a very young age. Well, Denny McLain didn't have the same problems during his career, but he developed it later on. He called me this year. I'm scheduled for a knee replacement, but I don't really want it. How does this stem cells all work, and what's the science behind it? So I started explaining it to him, and I started discussing some of the scientific basis for what regenerative medicine did. And then I explained to him what we're trying to do is catch patients earlier and earlier so they don't develop Joe Namath knees. And then he responded to me, you mean Denny McLain knees, don't you? And I thought that was kind of humorous because obviously they're apart and they have egos, as all athletes do. But if you look at them, these are not the same patients, okay? And so this is not cookie cutter medicine, and it's not simple. You have to individualize it for each particular patient. So Denny McLean is now over 300 pounds. His knee is not the same as Joe Namath's knee. And so there are differences in patients. So it is a more complex issue than just saying we're going to put a cell in or we're going to apply a certain strategy to each patient because they're all different. So in the acute stage, when somebody's injured, you get pain and swelling, and depending upon the type of injury, if it's an ACL or an MCL or medial collateral or meniscal injury, you're going to get an associated level of trauma and some immediate cell death. Mary Goldring has said that if you have disruption of the collagen network, then it's irreversible. So if you think about the injury and then you start thinking about what has actually been disrupted, like that weightlifter that you saw earlier, it's pretty clear the trauma that was involved there is going to be irreversible. Therefore, arthritis is inevitable. And the subacute phase is actually within the first few months, and you get a spreading of the cell death or the apoptosis actually spreads beyond the original site of injury, so it can be become more advanced. And what I see is a lot of people who think that they're going to get better, and they use the old Rice principle, rest, ice, compression, elevation. They think it'll get better, but in actuality, as Susan pointed out, that there may be this therapeutic window when people need to be treated acutely, and they just don't ever present to a physician because they think it'll get better. The chronic phase is actually just a spectrum of OA where they're going to be on this curve. They have this irreversible injury, and then it's just a matter of time how fast it progresses to the end stage where you're looking at a joint replacement. So we're really just dealing with a spectrum of time, and if our goal is successful, then we're going to deter it or delay it or prolong it so it is less of a problem for the patient. If there's blood in a joint or a hemarthrosis, there are certain things that happen. It induces a reactive synovitis where the inflammatory cytokines help to propel this. The hemosiderin molecules will actually induce more cell apoptosis. So if you have a very large hemarthrosis, it actually makes medical sense to drain that to get the blood out of the joint because it does damage initially. In cartilage repair, we're actually looking at the balance of whether we have anabolic or catabolic factors. If the cytokines are leading more towards a degradated pathway and it overweighs the anabolic pathway, you end up with degeneration. So our job is to try to see if we can balance this or actually tip it in the anabolic direction where you're actually getting repair. It's more complicated than that because there's repetitive injuries from mechanical factors. These athletes are continuing to beat up their joints, so it isn't just a one-insult thing. We're putting them back on the field the next week, and so we have to consider that. There are genetics. Some people have good joints. Some people have bad joints. The inflammatory mediators, nitric oxide, prostaglandin E2, all these things can perpetuate the cycle. Even anti-inflammatories may actually propel it by inhibiting some of the necessary feedback loops. There's systemic overweight in some of our athletes, and then just continued trauma. We can monitor some of these effects by analyzing the breakdown products of the degradation cycle and perhaps use that data treatment. Fat, as I said, can be a very detrimental thing. We have football linemen who are over 300 pounds, and that's in our society now the norm. But if they're bulking up and they're eating everything possible, a lot of them that I found are very inflammatory, and the inflammatory fats secretes not only cytokines, TNF-alpha and interleukin-6, but adipokines that act just like the catabolic cytokines, and this can be a problem not just for our athletes, but for many of our patients as well. As Susan pointed out, the experimental model is quite interesting. I've learned a lot from that. We know from taking the meniscus out of a goat, if we take the entire meniscus out and put cells in, we can get some repair. Rabbits will spontaneously repair to some extent, but goats and sheep and humans do not. So we can use these as models, and if we deliver a certain impact load, as Susan described, we will get arthritis, and there's a therapeutic window where you can prevent that. More elaborate studies that they've done with BMP7 and IGF-1, there's a synergistic effect. So if we know there's a therapeutic window, then perhaps we can make a difference by treating patients early and aggressively. This is an experiment I did on myself. I thought it would be smart to use very large skis and throw myself down a mountain very fast. So what I did was I tore my medial meniscus and my ACL, and this is a picture of my arthroscopy. And at the time, I was awake, and I thought this was very fascinating, and I was watching my friend, who was the orthopedic surgeon, take pieces of my meniscus out. Now that I'm into regenerative medicine, I look at it and I'm slightly appalled, because what he's doing is he's pulling parts of my meniscus out. So if you abide by Dr. Goldring's statement that disruption of the collagen network is irreversible, I think that looks rather irreversible to me. So lo and behold, 17 years later, I've got quite a bit of knee arthritis. So I'm stuck with a decreased medial joint space, and I'm facing eventual total knee replacement, which is not very amenable to me, as I'm a very athletic person, and I don't really want knee replacements. So as some of my patients who are athletes, I opted to pursue cell therapy and see what difference it would make. So first you got to get some cells, which I had a friend harvest some cells, and then I put the cells in my own knee, as any good experimenter would do. And then this is mine, radiographs 7 months later, and I definitely have improvement in my medial joint. Not all patients will repair cartilage, and I have my own theory, because I've seen so many different types of patients. Their patients are not all the same. My experience is young, healthy athletes do extremely well, and they regenerate pretty well. There are some patients who just do not, but I'm quite pleased. I'm asymptomatic, and my goal is to never have a knee replacement. There's all kinds of different mechanical stress, from just overloading the joint. If you're squatting 500 pounds, that's a definite load. It makes sense that you're overtaxing your joint. You can put shear stresses on the pericellular membrane and induce damage to the chondrocyte, or you can just have excessive weight. For every 10 pounds of weight gain, we get 30 to 50 pounds of excess force on the knee, which compounds it, which is quite common in our society. Not only the load effect of being overweight, but the inflammatory fat induces more inflammatory changes inside the joints, so it's a compound problem. This is my first 300 plus pound patient who actually did everything I said. She was 357 pounds, and no one would operate on her knees because she was morbidly obese, so she was too great of a risk to replace her knees. As you can see, she's got no real joint space, and most surgeons would love to replace that knee, but because of her weight, did not want to do it. As a last result, this is not my ideal patient, but there really wasn't much other choice for us in this particular situation. So she adhered to my recommendations, fostered a healthy lifestyle, lost weight. This is 1 year post stem cell treatments to her knees. She went from 357 down to 150 pounds, significant weight loss. So she not only decreased the load on her knee, which is beneficial, but there is some reparative effect, more so on this knee than the right. But this is still a bad joint, but she's functional. She's not having any pain. The problem is she's only 51, so we're probably going to have to follow her very closely because her knee will continue to have problems as more time goes by because she's only in her 50s. And this is a patient who's a 418-pound football player. He smokes, he drinks, he's diabetic, he has heart disease. He doesn't want to follow any of my recommendations, and he's not going to do well. This is a 300-pound bodybuilder, and just because you have muscle, it's still too much weight on your joints. So what are our options if these patients present to us and they're not surgical candidates? Anti-inflammatories do not deter the long-term arthritic process. Corticosteroids do not. So in our world, we have the ability to do translational medicine now, and we can apply these to the appropriate patients and get some very compelling results. There are biologics, which isn't discussed at great lengths, and scaffolds. We could talk at great length about nutraceuticals. In an experimental model, you can find a laboratory study that will show you can almost stop any process in the lab, but in humans, in proving it clinically, it's very difficult. PRP, the growth factors, may have some anti-inflammatory effect, but it's my personal belief without the addition of cells, especially with aging patients, you're not going to get the same therapeutic effect with osteoarthritis. Cells are much more complicated. There's all these different interactions with the cell surface receptors. Not only the immunomodulatory effect to decrease inflammation, but there are cell matrix effects, and actually CD44 will bind to hyaluronic acid, which is quite interesting because a lot of physicians will use hyaluronic acid as their scaffold. But is the cell matrix receptor supposed to dock to the aggrecan hyaluronic acid, or is it supposed to dock to the hyaluronic acid injecting into the joint? Nobody's quite been able to point that out to me, but I think at this point we're in such unknown territory that perhaps Mother Nature put that receptor there for a different reason. This is a study from Osiris that did show results, but it wasn't good enough for their desired effect to get it FDA approved. They had about 70% improvement. Their problem was that they took over 50% of the meniscus out. If you take 50% of the meniscus out, you're going to get less than desirable outcome. So the study was flawed, but there were patients who did improve. Quite often I'll get people who say to me that, is this placebo? And I always counter with, you can't make a racehorse run faster if it's lame. And so I think the veterinary model is very good. And also the athletic model. Athletes generally don't respond to placebo, especially when they have financial gain to get better. This particular football player had his knee operated on. It didn't get better. It kept swelling, so he came to me because he was cut. We did some cells on him. The swelling went away, and he got re-signed by another team and has made it to the playoffs. This is another professional athlete, a baseball player. He had 2 knee surgeries by 2 of the biggest names in sports medicine, continued to have problems, did not get better. He was cut, and I ended up treating him, and he again got re-signed by another team. His agent flew out to see me from Beverly Hills and was very interested in this science. And when I started explaining, arthritis progression to him, he got rather excited and had a twinkle in his eye. And I think the twinkle was that he realized if I could extend his playing career, then that would translate to 10% commission for a few more years. These are some teenage athletes that I've had that they were going to fuse her ankle. And if you fuse a teenager's ankle, especially a female, you're never going to play soccer again. But additionally, you're never going to wear high heels. So even the psychosocial effects from surgical alternatives are quite drastic. So these patients look for alternatives, and offering this, and this particular patient returned to soccer, and she's now being scouted by Division I schools. This particular ballerina couldn't dance, and she had toe pain. And ballerinas that can't dance have to have a big problem because they usually have significant toe problems. So we put some cells in her toe, and she didn't follow up with me. I finally found her 6 months later. She told me that she was back on tour and she felt great, so she didn't feel a need to call me. But I figured that if a ballerina can't dance, then they're really hurting. This particular patient had AVN of his wrist, a scaphoid bone. They wanted to fuse him. He was a high school athlete who got a Division I scholarship, and they were going to fuse his wrist. If he can't row, he loses his scholarship. So he found me, and we put some cells in him, and now he's rowing, and he's in college, and he's very happy. This is a patient with bilateral TFCC tears. He's a physician. He was not getting better, so the recommendation of the surgeon, one wrist up and one wrist down. He's an athletic physician, so he didn't find that to be a very palatable option for him. So we put cells in both wrists. He still has some pain, but he's lifting weights now, and he's quite happy. This is a 26-year-old who fractured her hip at age 10, so her arthritis developed at age 10. Her hip continued to wear. They want to replace her hip at age 26. Well, if they do, it's going to wear out again, and then she'll end up with a hip fusion at a very young age. So she opted to have cell therapy, and we've now treated her. She's asymptomatic. The problem with her, she's very young, so we're going to have to manage her for some time. But the alternative of having a hip replacement at 26, this provides an option. This is my last patient that I want to talk about. She's 92. She has a pretty narrowed medial joint on this side. This side is not nearly as bad. I certainly have much worse patients than her, despite her age of 92. Her children said to me, "How long is this going to last?" I told her that no one has that data. I've done quite a few 90-year-olds, but so I said to her, given the fact that your mother is going to live to be 120, we may have to repeat it. So they went along with it, and when I got the mother alone and we were doing the procedure, she started talking about her where she grew up in Scotland, and she said her mother lived to be 103. So I said, well, that's an important piece of information. This lady may live quite some time, so now it's a quality of life issue. So if I get this to last to 97, and she's ambulatory and functioning home, it's a success. And if we have to repeat it at 101 and she exceeds her mother, well, that's still a good thing. She's ambulating now without any assisted vitals and is quite happy. Thank you.
Well, thank you. In the interest of time, please see Dr. Lux, during the coffee break. Our next speaker, Dr. James Shirley. I introduced him early. Now he's going to come and talk about his work at Asymmetric. It says, asymmetric self-renewal, the fundamental property of tissue stem cell is the fundamental principle that medical
Okay, we're running a little bit behind schedule, but since I'm also co-chairing the next section, I'll tell you we'll get caught up. So I'm going to get started in the interest of time here. What I want to talk about today is something which is asymmetric self-renewal as it relates to adult tissue stem cells. And in the context of this meeting, I want to talk about how it's a fundamental property of these adult tissue stem cells, and it's also a very important principle for thinking about how we do the medical engineering of tissue stem cells. So I just want to start off with this conflict of interest disclosure statement, because Asymmetrics is in fact a for-profit company, and many of the technologies that I'm going to talk about today are technologies that we are currently trying to commercialize. So there are three main areas of stem cell medical engineering that I want to address today with respect to asymmetric self-renewal. One of those is transplantation medicine, which we started talking about this morning in my keynote address. I want to spend some time talking about tissue engineering and also drug discovery as it relates to stem cell medical engineering. So just to review again, stem cell medical engineering from the standpoint of transplantation medicine, the idea is that we have individuals who have a problem, in this case, the pancreas. What we like to be able to do is to replace it with cells, or in this case, cells from a person who's potentially could be a living donor, to improve the state of health of this individual. We want to keep in mind that some of these transplants are also from deceased individuals as well. It's an important part of the donors for these transplantation medicine. In terms of our second category of tissue engineering, it comes in a lot of different forms. One of them is taking cells from an organ and in culture expanding those stem cells so that we have more of them to provide to more individuals for transplantation medicine. The same strategy of expanding cells can be used to create engineered devices that might be more efficient for returning to patients, may solve problems like immune difficulties. And again, the idea here is that by developing these engineered systems, one might be able to help more patients. And by drug discovery, what I mean is, again, taking tissue stem cells and having them in form and in number to allow us to either do engineered systems for screening for drug effects, for screening for drug toxicity, ultimately to develop pharmacological agents that can affect the same types of changes in terms of patients as the cells have. So these are areas of stem cell medical engineering in a broad category, and what I want to turn to now is talking about why asymmetric self-renewal is important for each of these. And to get us to that point, I need to first address the cells that we have currently available for doing stem cell medical engineering. There are three major types. There are some other ones that aren't talked about as much, but embryonic stem cells, induced pluripotent stem cells, and adult tissue stem cells. Now, in terms of source, and each one of these cell types used for medical engineering has special properties and also some important challenges. And one of the challenges for embryonic stem cells has to do with their source. They're from donated human embryos. Those embryos have to be destroyed to create the embryonic stem cells, and there are ethical objections to that because of the destruction of human life. Some of the special features of embryonic cells is that they have multiple types of cell differentiation. This is both a plus and a minus. The plus side is you have one type of cell that can give rise to many different types of tissues. The downside is that typically when we're doing cell therapy, we're only really interested in transplanting one type of tissue, and these other forms of differentiation lead to a need to be able to purify out the specific cells that are needed for a given transplantation. There's also the problem of getting rid of any undifferentiated cells which are tumor forming in mature tissues. Now, one of the things that we've now learned over time that wasn't appreciated 10 years ago is that we don't get the desired mature differentiation from these cells. In most cases, these cells differentiate into cells that are closer in development to them. They're fetal differentiation. There's a question whether the fetal phenotypes are sufficient for drug development for adults and children and for transplantation into adults and children to achieve the same types of functions as adult tissues. And I've alluded to the inherent genetic mutations that are part and parcel with making embryonic stem cells. Those mutations are problematic in terms of forming tumors and mature tissues, and they may also compromise the differentiated cells that are produced from embryonic stem cells. Now, everything I said here for embryonic stem cells apply to induced pluripotent stem cells as well. One of the differences, though, is that these cells can be produced from individuals who have disease, and so one can get disease models with induced pluripotent stem cells that are not possible with the embryonic cells. But all the other caveats still apply, except for the ethical one, because these cells are derived from adult donor tissues, and consent can be done to do that. Now, adult tissue stem cells are found in both adults and children, and they can be sourced by appropriate consent. The challenges here is, as I mentioned earlier this morning, these cells, generally speaking, are difficult to expand. I'll talk a little bit about that. There is some progress. Our company has a technology called SAC, for suppression of asymmetric cell kinetics, which is providing some relief from that problem. One of the big advantages in terms of being able to make mature tissues, these cells are tissue-specific in their differentiation. Stem cells from liver make liver stem cells. They do it spontaneously in many cases, in the sense of generating mature cells as opposed to immature cells. And the defining and unique property of adult stem cells is what I want to talk about today, is asymmetric self-renewal, which is distinct from both of these other cell types. So there's a very common, pervasive stem cell definition. Most of us know it. We say stem cells, you're a stem cell if you can self-renew and differentiate. Self-renewal in this case, I'm showing a symmetric self-renewal where stem cells can divide, make two, essentially the same cells as the dividing cell, or undergo differentiation where division gives different types of cells. So this definition is not quite adequate for defining adult tissue stem cells. And the reason for that is because something happened with this slide. Yeah. The reason for that is that we need to say a little bit more. So the mnemonic, the thing which names the adult tissue stem cell, is this ability to undergo asymmetric self-renewal, defined by self-renewal and differentiation, two additional words, continuously and simultaneously. And that's what's diagrammed here, that these cells undergo asymmetric self-renewal, which means they can divide, give rise to a committed differentiating lineage, and they maintain their stemless state. And we'll talk about in a couple of moments about the manner in which this is achieved. But that's the defining feature. And that's what we want to talk about, because very often this is overlooked, and yet it's very important in terms of thinking about engineering these cells for medicine. I want to make a distinction here, because there's asymmetric division, which occurs during embryonic development, occurs in the development of mature tissues even as we sit here now. So there's no question about asymmetric divisions. But what we're talking about here are these asymmetric divisions that are different in terms of asymmetric self-renewal. So during development, there are asymmetric divisions where the two sisters are different than the parent. But importantly, both sisters differ from the parent in many cases. And these divisions are limited. They occur during a certain window of a developmental program. They don't occur for the entire lifespan in those, unless those programs are still running. In terms of asymmetric self-renewal, again, the two sisters, this cell and that cell, are unequal. But one of the sisters is different. One of the sisters is exactly the same as the parent. That's the idea. And this is continuous over the lifespan of the organism in which these cells reside. Just want to make that distinction. I want to give you one example of this. There are many, many more. This is the crypt villus unit of the small intestines. How do we know stem cells exist in these units and we can't see them or we can't count them? It's because of the turnover. This system looks static, but in fact, it's constantly turning over. Cells are being produced here by asymmetric self-renewal of tissue stem cells. They're giving rise to the cells that undergo differentiation, and ultimately out here, those cells undergo cell death. That process requires that these cells divide and make something different and don't forget who they are. They retain the program continuously throughout life. That's the asymmetric self-renewal. And there are many other examples of it in mammalian. So what I want to turn to now is how the asymmetric self-renewal is a factor in each of these different types of stem cell medical engineering, starting with transplantation medicine. So the top here, which I wish I could make this bolder, I want to talk about why the pluripotent cells, embryonic and induced pluripotent cells, are not adequate for transplantation medicine. And the reason is because they have self-renewal and differentiation, but it's actually self-renewal or differentiation. So when embryonic cells or induced pluripotent stem cells are proliferating, they maintain their stemless state, but when you tell those cells to differentiate, they stop being stem cells. They are converted from this form to these phenotypes here, which are non-stem in nature. Right? So that's how we achieve the production and making large quantities of the differentiating cells. But this is a problem for doing transplantation medicine. In contrast, adult tissue stem cells, which have asymmetric self-renewal, do self-renewal and differentiation continuously and simultaneously. Now, there's a lot of debate that's been going on for 50 years about how this is accomplished. Maybe even one of these isn't the right way. But there are two sort of competing notions. One is that the cells do deterministic division. An individual cell divides, reproduces itself in something that's going to be the progenitor for a committed lineage. That's shown here. But the same thing can be achieved by having small populations of stem cells where some are undergoing these symmetric divisions, making more stem cells, while others are undergoing differentiation in a balanced fashion. The net is the same idea. We have systems that maintain the program for the tissue while producing the differentiating tissue. Now, that's really important if you want to do transplantation medicine and have long-term repair. This is a schematic here of a quote-unquote normal tissue with asymmetric self-renewal divisions taking place, like our skin, our hair, our liver. Damaged or diseased tissue, we lose these units somehow. How do we repair them? Not so well if we use the pluripotent approach, because we can take pluripotent cells and generate these differentiated cells and put them into tissues. But depending on the turnover rate of that tissue, this is not going to be a long live repair, because these cells cannot recapitulate the entire tissue. It's just that basic. So the repair is going to be short-lived, and if you happen to put some of the actual pluripotent stem cells into the tissue, tumors arise because of it. In contrast with these tissue stem cells, those stem cells which have asymmetric self-renewal, if you put them into tissues, they will over time reconstitute this tissue, and they will do it continuously and for long periods. This is classic bone marrow transplantation with hematopoietic stem cells. So this is an important principle for transplantation medicine for long-term replacement and restoration of tissues. I want to turn now to asymmetric self-renewal in terms of tissue engineering. Why is it an important principle there? I'm going to focus on, there are many aspects of tissue engineering as I showed you. One of them is having stem cell biomarkers. All right, so markers that tell us we're looking at stem cells specifically that would allow us to count them don't really exist now for most types of stem cells. This asterisk is for me to remind me to say that this is also important for transplantation medicine, where we do stem cell treatment not knowing the stem cell number, and for drug discovery, as I'll mention at the very end of my talk. So here's this is the current dilemma of biomarkers for tissue stem cells. I'm going to just sort of say there aren't any, in the sense that they are specific for stem cells. This is best illustrated where our best biomarkers are for the hematopoietic stem cells. The reason this situation exists is because the cells are scarce, which means it's hard to get enough of these cells to actually be able to do a good job of finding specific biomarkers. We don't have good quantitative assays, so our assays aren't quantitative. It makes it, again, to know the number of cells and be able to come up with better biomarkers for them. This is illustrated here for a very well-characterized clinical population that contains hematopoietic stem cells. There's no doubt there's hematopoietic stem cells because you can do two things with them. You can rescue patients who've had their bone marrow ablated, and you can also show that in animals these cells will in fact give rise to all of the human hematopoietic system cells. However, for every 10,000 mobilized peripheral blood cells, for the one hematopoietic stem cell that's in that preparation, which is a low fraction, there are about 100 CD34 cells, and there are about 50 CD133 cells, because they share the same marker as the hematopoietic stem cell which gave rise to them. And because they're so much more predominant, this ends up not being it's a great biomarker to have, but you can't use it to quantify stem cell number. Right? And that's challenging for lots of things we like to do in stem cell engineering, not being able to quantify these cells. So one of the things that we've been working on is concepts for coming up with more specific biomarkers. I just want to mention one approach briefly. We've been looking for genes which are strictly associated with asymmetric self-renewal. The idea is that asymmetric self-renewal is much more specific for many types of tissue stem cells. If you find markers that are specific for the cell undergoing asymmetric self-renewal, you may have a better marker, a more specific stem cell marker. I just want to give you one example of one of our candidates. We call these asymmetric self-renewal associated genes. This is a protein that's known as CXCR6. We're looking at a system that allows us to tell the difference between symmetric and asymmetric divisions by stem cells. There are two cells here. They're recently divided. Here are their nuclei. We can score this as a symmetric division because they both show the cyclin A, which means they're both going through the cell cycle. Their CXCR6 expression level is more general in the cell and low. This is an asymmetric division where one of the daughter cells is actually going to undergo differentiation. The other one is an asymmetric self-renewing stem cell. And what you see is that CXCR6 is very strongly expressed in the nucleus of that cell. So it'd be great if this was even on the surface, but the basic idea is that we want to find, and we've been characterizing these biomarkers which are specific for asymmetric self-renewal. We think they're going to be the best ones of getting us to the point where we can actually quantify stem cell numbers specifically. I want to close with drug discovery. It's one of the most exciting things happening in our company right now. And the challenge for drug discovery, where you want to learn things about the responses of stem cells to maybe activating agents, or the responses of stem cells to drugs that are toxic to them, which make for very bad drugs, is that we can't identify them exclusively, as I just mentioned, because of the biomarker problem, which means we can't count them. So how do we assay for effects on tissue stem cells when we lack these two abilities? Well, we take a computer simulation approach. It's a little bit far from the problem, but the basic idea is that if we have a good computer model, that we can infer what's going on with stem cells because of their asymmetric self-renewal output. And that's based on the idea that when you take primary human cells and put them in culture for long periods, the cell that's most important for the longevity of that culture is a cell that has the longevity for growth capacity, which is the stem cell. So some of you may be familiar with these types of plots where you look in time, in culture, serial passaging, primary human tissues, and you follow the cumulative population doublings. These are characteristic curves. There are no exceptions for normal human tissues. You hardly ever get to make categorical statements in biology, and one should be careful when you do. But I like saying that one. What you see for any human tissue, if you put it in culture and you serially passage it, so you let the cells fill up the vessel, you take a fraction, you transfer it and let it happen over and over again. Doublings go up with time, but eventually what happens is every culture is going to stop dividing. The only exception actually is a P53 mutant, half heterozygous mutants, which in fact don't do this, but most of them do. So we say this is based on asymmetric self-renewal, based on this model shown here. This is a stem cell. There are about 4 different things it can do. In culture, it can die, it can not divide at all, it can divide symmetrically, as we've talked about, it can divide asymmetrically. And when it divides asymmetrically, it gives rise to these sort of tissue units where cells undergo transient amplifications, but ultimately they all stop dividing. And that arrest that we see with time, we propose, is due to these cells which are low in number and which don't divide this way nearly as much as they divide in this manner. This is the default. They get diluted out by their own differentiated progeny. Over time, you just lose them by dilution. Now, in computer simulation and modeling in general, the likelihood that what I just showed you is true depends on analyzing data. We've done an experiment, classical sort of, so we have data, and we fit our computer simulation to it. And the first, how well can we fit the data with these ideas? And we do very well. So these are data here. There are actually 6 individual cultures followed serially over time. They show the increase in population doubling, but they all stop dividing at some point. This dark line here is the average of them. And you can see they stop at different times, and they stop at different levels. That's an inherent variance that reflects, in fact, the stem cell behavior and a lot of other things. This is our simulation of that data. And you see we do a very good job not only modeling the magnitude, but more importantly, the variance that's there. And when we're able to get good fits and simulations to data like this, we can then go in and deconstruct the model and ask specific questions about the components, such as what's happening to stem cell number versus time. And that's shown here, where this is actually number of stem cells in these cultures versus time. It's a simulation, it's our prediction. What you see is these cells increase, stem cell number increases as the culture grows. The sudden drop is because we split the culture. And then we get growth again, but you notice the growth doesn't reach nearly the same level. It's because of the dilution that's taking place. There are actually fewer stem cells being transplanted each time because of all of the other cells they're competing with. So that's where we are with this. We have a way of estimating stem cell number, any tissue that we can grow in culture. And we're currently talking to pharmaceutical companies about using this to either look for agents that can activate stem cells for growth, so stem cell number should increase in these simulations based on the data growth that we follow, or in cases where there's toxicity, which we're very interested in, finding agents that actually decrease stem cell number, change the way stem cells divide. So in summary, what I've shared with you is our ideas that asymmetric self-renewal is very important for stem cell medical engineering, but it's often overlooked. And since it's a fundamental of the nature of how our tissues work, it's going to be very important and an important principle in many aspects of stem cell medical engineering. And what I suggest today is that we need to think about incorporating this more into our practice, because that should accelerate our approach to better treatments for patients. Just want to mention my collaborator, AlphaStar Corporation, for the computer simulation work that I've done. And I'm going to stop there, and I'm going to be around for the entire meeting because I know we need to move ahead now. Thank you for your attention.
All right, I think we are a little bit, so I have 2 announcements. We're going to have delivered. We have some certificates here, to the members of the organizing committee, and that will be followed by a group photo. I guess we're having group photo here.
Yes, sir.
So, okay, great. So, I think Dr. Yakanti was supposed to help me out. Is he around? You're going to have, no, come on. So we're going to have, this is the tradition, by the way, so I guess you can sort them out.
Yeah.
I'll just call up the names, and these are the member of organizing committee. This is to basically indicate our appreciation for their hard work in putting this meeting together. And Dr. James Shirley, so please come on up here, and Dr. James Shirley. Dr. Chan. George Chan, Dr. Chan. He's not here. Dr. Anderson. Thank you very much. So can everybody please can you come up here? I guess.
I would like to request to Dr. James just to facilitate this certificate to Dr. Shrivan. Just please come here. Thank you.
Thank you, gentlemen. Yes, ladies and gentlemen, if everyone would please make your way to the front, in the front row, if you please stand on the stage as well, we'll have our group photo, and then we can take our coffee break. If everyone please join us in the front, get nice and tight, shoulder to shoulder, side by side. We'll take a group photo, we can share it with you, and we'll take our group photo afterwards.
I guess we just have
Find a
to.
place.
Yeah, find a place. Yeah, it's gonna be. I don't know how it's gonna
It's going to be packed, so everyone, you can just kind of get on the stage as well, and then a few people in the front might be the best thing. Let's have all the shortest people on the stage. How about that? Single file. No pushing, no shoving.
We're almost there. Come on. All right, everybody nice and comfortable? Everybody ready? Want to take your spot? Everybody say high definition. Oh, what's that? Hang on, let's mute that. Thank you. Ready, guys? On the count of 3, 2, big smile, 1. There was no flash, that's okay. Thank you very much. Enjoy our coffee break now. We'll be back in about 10 minutes, okay? Thank you.
would definitely, this is Peter Quisenberry had a presentation.
Minutes of discussion, more or less. Anyhow, if somebody is going to go over the 15 minutes, 15 minutes are going to count. You know that you have only 3 minutes to talk. So, we are going to hear again a presentation from Dr. Shirvan, and he already introduced the data about this Protex technology, and now he will tell us more how this may work in increasing the mixed hematopoietic chimerism, if I understand correctly. So, thank you.
That's correct. Thank you. Thank you very much. So because it was my fault, I didn't quite exercise my power as a chairman and let people, go over time. I'm going to keep it really short. I already introduced, the concept, so I'll just present some data. As I mentioned, talk, we really initially we designed this concept for the purpose of cell-based, therapies. And hematopoietic stem cells has been of interest of us, especially Dr. Yoko is a long-term collaborator. She is the person really pioneered this concept in that setting. So the bone marrow transplantation, I don't have to tell you exactly its importance. The previous speakers, they already talk about this. But our purpose is to use bone marrow as a means of rebuilding the immune system for the purpose of inducing tolerance to foreign tissue. That's our concept, and the work has been done, a long time back. If you have mixed chimerism, David Sachs and Ilstad in early 80s demonstrated that indeed mixed chimeric recipients will accept not only allo but also xenograft. So it's a very powerful means of inducing tolerance because it goes through what they call, central deletion as well as peripheral immune. Pretty complicated. Now, what are the problems? These are three major problems in hematopoietic stem cell transplantation. The first one is being stem cell competition. You have to have a niche, and the way it is done clinically, you precondition the patients with chemotherapeutic agents as well as irradiation, etc., so that you open the niche for the stem cell that you're going to put in. And engraftment is certainly a problem. And then you are now faced with graft versus host if you have mature T cells in the bone marrow inoculum that you put in. And interestingly enough, the T cells are required for efficient engraftment. And still we don't know exactly how they do that, but certainly that's what it is. If you have stem cells alone, there is an issue for engraftment. And those T cells, once they enter a recipient, because they see the recipient antigens as foreign, they get activated, they attack the recipient. That's your graft versus host. And the opposite, of course, the host responds to the bone marrow as a foreign body. So we have to overcome all these three. And presently, as I mentioned earlier, you precondition the recipient in the clinic, put hematopoietic stem cells or complete bone marrow. Of course, immunosuppression is on board, etc. But I must admit, fortunately for the community as well as for the patient, there are recent work by several groups, in this country, especially where I am right now at the University of Louisville, Suzanne Elstad, demonstrating that indeed it is possible to achieve tolerance. This is done in the context of kidney transplantation. I think that data is very exciting. So our approach, can we use our concept basically to deal with these two aspects, these two limitations of bone marrow, that is graft versus host and host versus graft. And so we used SA-Fas ligand, this is a chimeric protein. Here is the technology, just to remind you again. And this is the model. So the model, we used C57 black 6 to BAL-C. Now, actually, we've also done the opposite. The same thing is true. 30 million bone marrow cells engineered with Fas ligand. And then we use irradiation, 300 centigrade, followed by 10 daily doses of rapamycin as an immunosuppressive and immunomodulatory drug. As I mentioned earlier, it has synergy with FAST-LOG, and I'm not going to go into it. And then we look at chimerism. So here is to show that, yes, bone marrow cells, you can put FAST-LOG on there. This is biotin, and this is streptococcus as a control protein, and this is FAST-LOG on the surface of bone marrow. If you notice, everybody has FAST-LOG on their surface. And then when we do transplantation, you follow the animals, for donor chimerism. If you notice, the group that have received FAST-LOG and on their surface, they are chimeric, but not the control group, the bone marrow cells with streptococcus and rapamycin. And then at the end of experimental endpoint, when those animals were analyzed, there is multi-lineage, chimerism, in these animals. So FAST-LOG, it prevents, the in this setting, and it established, multi-chimerism. One thing is important in this context is that FAST-LOG has tropic effect on stem cells. Somewhat differentiated stem cells, they express fast and they're sensitive to FAST-LOG mediated killing, but not undifferentiated, truly hematopoietic stem cells. So that is something Nadir Askanasi actually published this data. It also helps basically engraftment. We don't know how that happens, but it's something we're looking into it. And then if you go ahead and do the transplantation on this animal, this is skin transplant, and all of these animals except they did not reject the skin coming from donor, but they rejected the third-party skins, which has been shown by many others. So in this configuration, FAST-LOG prevents the rejection. Now the problem with this model is that the second issue is graft versus host disease. In a rodent model, you don't see graft versus host disease that you see, for example, in non-human primates or in humans. So we wanted to establish a model where we see graft versus host disease, ask the question whether FAST-LOG can prevent graft versus host disease. And the reason we think it would is based on, again, this cartoon right here. T cells, when they're naive, they don't express fast, they get activated, upregulate fast, as well as FAST-LOG. And upon repeated encounter with antigen, they become sensitive to FAST-LOG mediated killing on the same cells or different cells, and you eliminate them. So we thought if we put FAST-LOG on the surface of T cells, mature T cells, when they get activated, they should express fast on the surface. Therefore, they should be sensitive to actually FAST-LOG mediated killing. So conceptually, it makes a lot of sense. And it doesn't really happen, and here is the model. So take bone marrow cells. This is, again, C57 black 6, or you take splenocytes, you do your engineering, and simply you take, we use F1, 57 black 6 by biopsy, so these animals, clearly they're tolerant, to 57 black 6. They will not respond, to the graft, but the graft, the mature T cells in the graft should respond and kill these animals, and that's exactly what happens. So again, showing that you put FAST-LOG on the surface of both bone marrow cell as well as splenocytes. And then when we look at apoptosis in vitro, if you notice, cells that receive FAST-LOG, they undergo apoptosis, okay? And this is the control. And these are primarily, T cells. They get activated. This is in vitro mixed lymphocyte reactions. You take those cells, you look at them. They undergo apoptosis, and we've shown in vivo, actually, the same thing happens. Now, when you transplant the bone marrow cells with splenocytes in different configuration, you have irradiated control. Everybody basically expires from acute graft versus host disease. Bone marrow splenocytes, the same thing. Bone marrow, and showing that, yes, this model developed actually graft versus host disease, okay, because you have splenocytes and you have bone marrow. Bone marrow should rescue. We don't have that control here. And then you have bone marrow splenocytes with streptococcus. Again, those animals from graft versus host disease, the only group they don't expire from graft versus host disease, those are the group they received splenocyte engineered, FAST-LOG engineered splenocytes, or double engineering. So in both configurations, this regimen actually working very nicely. Okay, so if you look at the body weight, and again from body weight, these are the only group they basically maintain a study body weight, and this is looking at basically scoring the graft versus host disease. Again, these are the only two groups they did fine. Okay, this is again, this is just show you some picture. This is the control group, and these are the animals they've received fast ligand, so they're clearly looking like normal animals. And so we're now trying to further, work out, this regimen. So the idea from our perspective is that can we get down maybe to low level of irradiation in patients, clearly 200 centigrade is being used clinically, approved by FDA, but we're hoping maybe we can improve it further so that we don't need to use irradiation. So we're playing around with some concept, as I mentioned earlier to you, is that our advantage is that not only one molecule, we can put 2 or 3 molecules with synergistic action, and indeed we've done it with another molecule. I'm not going to disclose it here, but in that configuration, it is extremely potent. You get beautiful engraftment at lower, irradiation. So the idea can really get rid of irradiation. So with that, it seems to be it's pretty effective and clinically clearly conducive, approach, because you're not really doing much. The whole process is pretty straightforward. And with that, I appreciate the people that actually did the work. Again, Nadir Askanasi is a long-term colleague. He did most of the bone marrow with Esma Yolku, the funding source from NIH, American Heart, and others. Thank you.
Thank you very much for keeping in time. Actually, you did very well. If there is space for one question.
Do we have any questions? Dr. Shawan, no? It's fine.
Well, we keep on going, so thank you very much.
My pleasure.
Now is the presentation of Dr. Gary Guisao. I'm sorry, that's the pronunciation, from the University of Technology in China. And I'm not so sure, is it the same title or is it change your title?
Oh, same, exact same.
Yeah.
Okay.
So it's going to talk about this regulation of MIR34A and how this is important in this breast cancer stemness.
Yeah, thank you. Where bring my
Parkinson's disease. The work I'm going to present here, coming from my academic lab located at the Buck Institute in the San Francisco Bay Area. And part of the work also coming from Excel Science, which is a company I set up, leased the space here at the Buck Institute. So let me just start with a very brief introduction of the disease. Parkinson's disease is a neurodegenerative disease involving motor function caused by the death of dopaminergic neurons in the substantia nigra. So currently there are many treatments, for example, like increased dopamine levels in remaining cells, or give a pseudodopamine like the dopamine receptor agonist, or preventing breaking down of dopamine in the brain. They are also surgical procedures available, for example, like deep brain stimulation. But all these are just treatments. There is no cure for the disease. So this leads to what I'm going to talk about, cell therapy. In the past 3 decades, there have been clinical trials using fetal cells, so pioneered by the Swedish group and the US groups. So those studies really proved the concept of using cell as cell replacement therapy for Parkinson's disease. For example, the graft dopamine neurons, they can reintegrate the striatum. They can restore regulated dopamine release and also improve the motor function of the patient. But there are also a lot of problems associated with fetal transplantation. One issue is the limited materials. For example, one patient, you have to use about 4 to 6 fetals and combine the cells. And of course, when you are using such cell prep, you have a lot of variabilities of the outcome. And the worst side effect is the dyskinesia. So we think all these issues could be addressed by using alternative cell source, which is the focus of my presentation in the next 10 minutes. We're using human pluripotent stem cells as the start point. And also, not only these cells can be obtained in a large numbers, they, in theory, also because of the IPS technology, so in theory, you can use autologous therapy. So this is really what I've been focused in the past decade when I started working at the National Institute of Health using human embryonic stem cells to derive dopamine neurons. So what I want to tell you a bit about is our recent progress in terms of getting an IND with the FDA. Does an IND process entail? It really start with academic idea with lab validation, of course, followed by the manufacturer, and to need to meet the requirement of the regulatory. In the US, it's the FDA, and perform preclinical and clinic studies. So here is the strategy what we have done. So first, we need to obtain clinical-grade cells, and in this case, we talk about both iPS and EA cells, and manufacture dopamine neurons in the cGMP facility, evaluate efficacy, safety, and the requirement for immunosuppression in suitable animal models, and design clinic protocols. So at this stage, we are in the progress of finishing up this and assemble the. So let me just start walk you through the process. So first, we have developed a stage-wise manufacture process of manufacture dopamine neurons, and start with either embryonic stem cells or iPS cells, and then we make an intermediate stage called the neural stem cells, which can be cryopreserved and also further differentiate into neurons and glials, and differentiate them further to dopamine precursor. This is the stage where we cryopreserve it and then transplant. Okay, so as far as I have known, this is the first report that we use the cryopreserved cells for clinic use and directly, we will freeze the cells down for the on-site manufacture to inject it into the patient. And these are the in vitro step, which really just to test if the cells can be mature in vitro. This is related to the potency assay. So this process has been transferred successfully to a CGMP facility. In my case, this is the City of Hope CGMP facility. So we have in the past 3 years and under a grant from California Institute for Regenerative Medicine, we have run 3 dry runs. And these are the cells we have manufactured. As you can see, is in a large number, which is enough for all the preclinical studies, and is intended for a phase 1 trial. But this is the dry runs. It's manufactured in the CGMP facility, okay? And we have used the cells to perform some preclinical studies, including efficacy and safety studies, as well as the surgical device test. I'm going to show you just a couple of this result. So for the efficacy, we use the 6-hydroxy-dopamine lesion rat model. So this is a very established model, lesion one side of the striatum and then transplant. So these are the group of animals receive control, and we also have a better control. This is the cryopreserved cells 4 days before the final product. This cells is considered immature and may not provide functional improvement. And this is the product stage, day 14 cells. At the time when we start this experiment, and since it's a 9-month study, I cannot really take any risk if the cryopreserved cells didn't work. So we also have a side-by-side study using the fresh culture cells. So these are the behavior outcomes. So after 3 months, that you can see the motor function is significantly improved, and this is done by the amphetamine-induced rotation test, which you can see the improvement increase and persist at the end of the study, which is 6 months. And we don't see any difference when using freshly prepared culture or use the cryopreserved culture. So both group didn't provide any functional improvement. So the function improvement is very associated with the survive and the differentiation of dopaminergic neurons. And this is the graph, histologic analyzed at the graph side, which you can see after 4 months of transplantation. Look at the day 10 control. You do see human cells, which is labeled by stem 1-to-1, but you don't see any dopaminergic neurons here. This is an enlarged mag of the same photo, and see the freshly cultured cells that you can see a lot of dopaminergic neurons survive and graph here. And the same goes for the cryopreserved cells, which you can see. Now, this is just another stain with the human nuclear antigen to pH. Again, you see the control group. You see the human cells, but you don't see the dopaminergic neurons, whereas you see the clear survive and in both the freshly cultured and the cryopreserved cell receiving group. So these are additional analyses with the midbrain markers, for example, like FOXA2 and LMX1A. And this is just shown with the freshly prepared cells and the cryopreserved cell transplant group. Again, you can see the fine axon extension of the TH positive cells, which remain expressing the midbrain markers. So the other study I want to tell you a bit about is the surgical device. As we are preparing for the IND filing, so we chose to use the FDA-approved stereotactic platform, which is already used for deep brain stimulation. The device we actually choose is one of what we are going to choose. We have done some tests. This is a radically branch deployment system. This is developed by my collaborator collaborator Daniel Lim at UCSF, and this is again the cassette attached to the stereotactic platform. And using this device, and Daniel has done the transplantation under the real-time MRI guide with these cells labeled, and you can see actually when you deploy the cells, you can see 1, 2, 3, 4, there are 6 of them. Okay, and this is done in mice actually to do the surgery. So when we talk to the FDA, ask about the device, and they indicate they want to see the safety data from a large animal model. So that's what we go with a swine model. Again, this is our cells as exactly the developmental stage, day 14. I show you the efficacy data, and we use a label line, and in this case we have the GAP label, and we injected this with exactly the same device I just showed you into the striatum of the swine, the pigs here. And this is 2 weeks after injection, which you can see the human cells both labeled by the GAP and also confirmed by human marker STEM121. So the paper has been published in Molecular Device earlier this year. So I'm not going to show you the data, but I do want to tell you we have done the tumorigenicity study, since this is a pluripotent stem cell-based therapy. So this is a 9-month study and done with the Jackson Lab, used a mouse, and looking primarily at any possibilities of tumor formation, which we didn't see any. And we are also at the same time doing the tox studies. So I'm going to end with, these are all the data I've been showing you from the human embryonic stem cell line H14, which has been manufactured by Weissman Manufacturer at Wisconsin. One of the lot funded by the NIH, which we have been using for deriving dopamine. So I'm going to walk you through, just show you 2 slides, the iPS cells we have been using. So this is our strategy to obtain cGMP iPS cells product, which basically start with tissue banking. We decide to use the CD34 positive cells as the starting material, and then get to the banking derived iPS cells, and go further to make neural stem cells expansion, or maybe need the selection and transplantation. This is the workflow. So I'm going to ask you not to take the picture of the next 2 slides. Okay, so these are still works undergoing, please. This is the lines that has been manufactured right now at Lonza. Okay, this is as far as my knowledge, is the first real cGMP iPS line. This is manufactured by Lonza under an NIH contract. Okay, so what we have shown here is you can start with CD34 positive cells with nucleofaction and make iPS cells, and go through all the characterization, ability to differentiation, and of course normal karyotype and the DNA fingerprint analyze. Okay, and this is the line I have acquired, and we study the neural differentiation with this line together with Lonza, and this is how we make rosette and make neural stem cells. Okay, and also I want to show you this one more face picture, or the picture images of we have been able to engineering it. This is by genome editing, and in this case we use the GAP just to target at the safe harbor. So in case we need the label cells for preclinical studies, and also for later for genetic engineering. Okay, so I'm hoping we are submitting this paper this week. So hopefully, after the study, and this will be the line with the intention that will be make it available to the research community. So with this, I'm just going to summarize where we are on the PD therapy. So we had pre-IND discussions with the FDA. We have access to clinical-grade EAC and IPS line, as well as the matched research grade cells. We have identified the manufacturer site and access to the drug master file, and we have performed preclinical studies with the cells manufactured by the particle process, and we have developed engineering subclones of the IPS line together with the H14 lines too. We have coordinated with clinicians on surgical trial design, and these are the papers we have published to support this IND enabling effort. So we have the manufacture process, preclinical studies, device test, and the engineering approach. So with that, I want to thank the people who contribute to this work, and my lab at the Buck Institute, and people at Excel Science, and my many collaborators. This is just three of the few. Mahendra Rao was the founding director at National Institute for Center for Regenerative Medicine. So he quit there last year, and he has worked with this effort with me and my long-term collaborator Daniel Lin, working with the device, and also this work is really the CGMP IPS line is done at Lanza. So my collaborator Thomas Farner there is in charge of this project. So I'm not sure I have time for questions.
I must have scared you.
Just one rapidly. I'm just curious, how do you are accreditation for GMP, good manufactured product?
How do I?
Yes, do you have an inspector that came on the seat? Do you have a standard, or is your company that decide that you are GMP level?
So I don't define that. This is a FDA approved inspector CGMP manufacturer, Flanza, located in Waxwell in Maryland. So I don't define, but everything is followed from the donor consent and acquisition, and every line they have like hundreds of pages you have to follow. Thank you.
So you are ready?
Ready? Thank you for your patience. Sorry about it. As I say, it's grateful to present my research over here. This work is done in China, new place. I'm going to join next month. Current situation is in UCLA and Creighton University in Omaha, Nebraska. This is through the international collaboration. I'm in charge of the School of Pharmaceutical Science and Technology. Barney is a beautiful, charming place to stay. That's why I'm joining them. So today I'm talking about the microRNA regulation in cancer stem cells. As you know, the previous several talks is heavily focused on the therapeutic agents development. Now I'm going to use the cancer stem cell as a target to develop a new agent called the microRNA, hopefully. I want to quickly through the cancer statistics. Everyone, as you know, breast cancer still is the number leading deaths of cancer in women in the world, even in the United States. just skip it. Why it is still the highest? It's getting better, but what the reason was generated the high incidence rate? And so because I know the early diagnosis is a big problem because we lack of effective tool approaches to diagnose earlier. But most important question is based on recent research, the recurrence and the relapse of the therapy, which is a major reason initiated and maintained by remaining cancer tissue stem cells from either residual tumors or those with intrinsic resistance to adjuvant therapy. So now that's why we focus on use the cancer stem cell as a therapeutic target. Now, specific focus on breast cancer stem cells. As you know, the cancer stem cells come from the stem cells. What's the exact etiology? Still unknown and not clear. It's going to come from the regular stem cell because it's during the process differentiation and mitosis. So there's a number of factors could infect the process differentiation mitosis, cause a number of the mutation. So this is I don't want to spend too much time on that. So we are interested in the two types of cells. As I said, CD44 and CD24 is two cell surface markers expressed in these culture cells. And we are going to use that as a tool, as a target to study the microRNA regulation. Quick through that, that's the biosynthesis of the microRNA initially through the pre-microRNA processed by the enzyme called DICER and translocated to the cytosol. Further processed through a number of the enzymes, especially DICER, and becomes a mature microRNA, perform the functionality. Through the previous study, I was done in Creighton and collaborated with UCLA Pancreatic Cancer Center, but pancreatic cancer is still working breast cancer as well. We are collecting tissues from patients, and this is some of the patient tissues from the Department of Pathology at UCLA and some of them from the Creighton Pathology. We are looking for focus on 3-stage benign tissue and DCIS and invasive cases. We found out through the RT-PCR platform, which we modified. We identified the number of microRNA, which is upregulated, downregulated. But most importantly, we think we're interested in the microRNA 34A. Of course, the number of other microRNAs, because the mechanism why this microRNA downregulated in the cancer case not clear yet. Most of this speculation because of the promoter of the microRNA is highly methylated, epigenetically regulated. So this study we are just to give us a heads up to see what the underlying mechanism of those microRNA, the cancer status. As you know, so hopefully, as I say, as a target to see if microRNA 34A can be developed as the therapeutic agents. Because this is especially for the cancer stem cells. We are starting from the use of breast cancer cell line, which is a mobilized cell line, is MCF7. As I say, MCF7 can express cell phenotype is CD44 and CD24. So we're interested in CD44 positive and CD24 low expressed phenotype. We use that as a target. We see if it's microRNA 34 can be regulate the process. Interesting, first of all, we look at the hypothesis. whether the SIRT1, okay, so SIRT1 is not an NAD-dependent enzyme. It's an amylase enzyme. This is, has been demonstrated as a target of microRNA 34A in other cancers, regular cancer. But why interested that? Because there's no one is work on the breast cancer stem cell. We don't know what the role of the this axis of microRNA 34A and SIRT1 play in the initiate or regulate the breast cancer stem cell process. So we first look at the endogenous level to see. As you can see from the first slide, it shows this is a parental cell line. It's MSM7. This is we separate use the markers. And as you can see, is microRNA 34 is significantly downregulated, and we can see the SIRT1, which target is operated. This definitely is a reciprocal relationship. And protein as well. You can see upregulating the breast cancer stem cells, and that is the chart plot. So that means demonstrate the reciprocal relationship between microRNA 34A and SIRT1. And now if we can manipulate the microRNA 34 and SIRT1 axis, see how this manipulate can affect the cell growth, stimulate cell. So we run this experiment by either downregulate the SIRT1 using the silent RNA, shRNA of SIRT1, or we epitopic expression of microRNA 34 in the cells. As you can see, we're using the different, this is silence the genes. You can see it's efficient and sufficient, suppress the expression of SIRT1. The 34, if we, the 34, same thing if we, first, this is a demonstrate the efficiency of the expression, of epitopic expression. And for instance, if the cell line overexpress 34A, we can see significantly suppress the SIRT1. We will see the endogenous level of this breast cancer stem cells. As you can see, the highly expressed in the, as we demonstrated previously. Now we will hypothesize if we by alteration of this axis, whether the alteration of the axis can affect the growth potential. We are using the cell growth colony counting cell counting assay, and we demonstrate it is either overexpressed and microRNA 34A or SIRT1 gene significantly inhibits cell growth. What about the on the other hand, we also run through the colony assay, colony formation. As you can see, 35A or expressed cell treatment is significantly suppressed, demonstrated by the chart or not done there. And if we silence the SIRT1 gene, it will show the similar pattern with significant, the colony formation is significantly inhibited. Now we want to see the cell behaviors, proliferation. We're using the dual staining PE versus the PhySI. As you can see, the MYR38 overexpressed cell line is generated pre-apoptotic cell death population, significantly causes cell apoptosis. What about the mammosphere formation? This is the mammosphere formation capacity is another features of the cancer stem cell of the self-renewal. As you can see, the number of mammosphere formation significantly decreased either upregulated male microRNA 34A or silence the gene SO1. Now, Arkansas will stand breast cancer stem cells. What the biomarkers in the surface demonstrated to see response behavior looks like. So we are looking at the LDH1, NANAC, and the BMI1. And those genes is consistently downregulated, treated with, in the cells treated with either microRNA 34A or silence the genes, silences SERT1 genes. This is the bar just demonstrate the significant difference. And now the question whether alteration of the this can suppress the important biomarker of the stem cells, NANAC. It is. This is the Debye staining, and which significantly shows the suppress the breast cancer stem cells versus compared to the control cells. And if we silence the gene, show similar pattern as we demonstrated in that by upregulated, by epitopic expressed the 34A. Now, the modulation of this axis can enhance MSF cells apoptosis. This is further demonstrate the relationship. I will just click through, and you will see the cells compared to the control. This is a control group. This is overexpressed 34A. This is a sinus SERT1. The significant inhibit. Okay, thank you. And now we want to say this is the previous experiment we done in vitro. Now, what happened to behavior in the tumor in vivo? So we are using the new animal mass to cells being eventually transfected using an antivirus and stem cell and injected the fat pad to see how the microRNA those behavior in vivo. As you can see, it shows a similar pattern as we demonstrated in the vitro. Either upregulated microRNA 34A or silence the genes of SO1 significantly inhibits tumor growth. This is the tumor size. As you can see, collectively found the tumor size is significantly inhibited by either upregulated or downregulated SO1 genes. And clearly, it shows the pathologic slice HE stain and shows the tumorigenicity, and SO1 gene, this is a treatment, this is a control. It's a significant suppressive expression of the gene in the tissue. RT-PCR further confirmed the xenograph, the expression of 34A suppressed the upregulating in the tissue, which is transfected, antivirus transfected. Protein level shows similar thing, is confirmed what we discovered in vitro. This is a kind of a tentative mechanism we propose, because as we know, transcription factor P53 is upregulated microRNA 34A. 34A has a number, microRNA has numbers of targets, can target ESO1, which is we are demonstrating on the other groups as well, as a directed target ESO1, and also target CD44 and Notch. This is a proof. Notch signaling is just published recently, cancer research by Dr. Song in China. Eventually target the breast cancer stem cells, but the mechanism in the downstream effector we still don't unknown. The mass of the study is undertaken. So I'm gonna talk right here. This is my the research, specific research through international collaboration before John's group, and Chinese government, no, the university has, we have won them grants. We went through the research. This is my fellow over here, United States, in creating a UCLA, part of a group. Thank you very much for your attention. Yes. Vector for the microRNA 34A lentivirus used in vivo. Lentivirus. Huh?
He asked the effect that this might have on normal stem cells.
Oh, normal cell. We honestly we didn't do that experience as well. Yeah, it would be interesting to look at it. But no. Normal cells we don't know yet. But however, based on a previous study, teacher study found a benign all the way to the invasive, we did see lower or higher expression in the microRNA 34A. But in the normal cell line, stem cell line, I may have a high expression level, but we didn't check it yet. But in the normal cells, it's highly expressed in the cancer cells, in normal cells anyway. But in normal stem cell, we didn't check it. That is the point we need to check it and to see if it's a. But still, another experience still under it's ongoing project. We should end it about 2 years from now. Yeah.
So if there are no more any other questions, I thank you, Dr. Xiao, and we proceed to.
Hello, everybody. I just would like to tell about P53 and its role in differentiation of neuronal stem cells. Yeah, thank you. P53 is amazing molecular, and it has thousand mechanisms to affect everything. Beginning from tumor suppressor and apoptosis, autophagy, cell cycle arrest, and including aging and proliferation. And also now we know that P53 also play a role in differentiation, and current research mainly concern differentiation of embryonic stem cells. But we were interested to find out what's going on about neuronal differentiation. And first mention about participation P53 in this process comes from late 19th. Then it was demonstrated that P53 expressed really highly during brain development in normal, and that this activity clustered in area that not correlated with apoptosis. Later on, P53 was detected in neuronal stem cells in a special niche, like lateral ventricular and in a subgranular zone of the hippocampus. And all this data confirmed that P53 play a role. And later, measurements demonstrate that activation of P53 really induce embryonic stem cell differentiation. And on the other hand, knockdown this differentiation. All this data confirm the role. But how P53 doing this? First of all, of course, P53 is a transcriptional factor and regulate many genes. And the main, what was demonstrated that P53 then phosphorylated at serine 315 inhibit NANOC expression, thus stopping proliferation and inducing differentiation. However, there are many other genes and the main P21 which play a role in the stopping of cell cycling and in the connection with GSK3 and prohibitins and C-ALP, P53 induce expression of P21, and also in this process play a role some post-transcriptional regulation like acetylation and even ubiquitination. However, P53 play a role also as a cytoplasmic and inhibit CDK2. And what's the main interesting for me, it's that I forgot to tell that P53 also induce expression of neurotrophin receptor, TRKA. And on the other hand, in the cytoplasm, P53 directly connected with this receptor and over-phosphorylation, and thus increase activity of MAP kinases. And this pathway playing significant role in differentiation. And also this pathway can be induced by other factors, not only neurotrophin receptors. But in the common activation of RAS, RAF, NEC, ERK leads to activation of transcription factor CREB. But on the other hand also, there is data that P53 can directly affect on this MAP kinase pathway, not through the TRK receptors, but directly, probably through some other molecules. But still, and what we did small experiments on PC12 cells and induced P53 activity by nuclein treatment. And what we see that this really induced differentiation of PC12 cells. And also what we did, we inhibit MAP kinases and thus prevent differentiation. And also the third group was the simultaneous injection of inhibitor of MAP kinases and activator of P53. And then we check what's going on with MAP kinase pathway. And we saw that RAF activity directly correlate with P53 activation. You see in the both group, then they induce P53, and in group then we induce P53, and at the same time inhibit MAP kinase. But downstream target of CRAF, it's ERK, and they see that activity of ERK was upregulated after P53 induction, but inhibition of intermediate player MEC completely prevent this activation. And this data let us suppose that indeed P53 act on CRAF or upstream. And also we check downstream target of MAP kinases, CREB, and also what we see is that P53 which induce MAP kinases use CREB activation. But CREB, the downstream target not for MAP kinase, but also for GSK3. And this transcription factor not activate but inhibit CREB biphosphorylation at serine 129. And on the other hand, GSK3 may directly connect with P53, thus induce acetylation, and also phosphorylate P53, which induce transcriptional activity, and also GSK3 can induce degradation MDM2 pathway. So this let us suppose that this molecule also can somehow participate in P53 regulation of differentiation. And in the literature, we know that low activity of GSK3 activate axonal growth and thus can differentiation. And high activity in the opposite prevent differentiation and induce proliferation. So then we switch our experiment to neuronal stem cells and use not only activator of P53, but also we inhibit GSK3 by small molecular inhibitor TCS 2002. And what we see, and it's quite interesting, that SOX2, after increasing P53 activity, just migrate from the nuclei, where it's usually expressed, to cytoplasm. And this data means, and it's confirmed by published data, that localization of SOX in the cytoplasm just means that this transcriptional factor goes to degradation. So the high amount of SOX in the cytoplasm means that reduced activity of SOX, and probably stimulation of differentiation by P53 goes not only through NANAC suppression, but also goes through SOX suppression. These both NANAC and SOX known players in proliferation and self-reviewing. So, but then we just inhibit GSK3. This saw nothing. We saw the same picture as the control groups. SOX stay in the nucleus, but then they count completely differentiated neurons or astroglial. We saw that even enhanced P53 activity or reduced GSK3 activity both increase the percentage of fully differentiated neurons. That's confirmed that low activity of GSK3 indeed induce differentiation. So, and when we apply both Nuclein and TCS, we saw even more differentiated neurons. And of course, we check, as in the previous study, activity of MAP kinase pathway. And we saw expression even in the early stage, in the stage of neurospheres, expression of phosphorylated P53 and active ERK, and then on a later stage too. And phosphorylation assay demonstrate that indeed even in neuronal stem cells, nuclein induce CRAF activity. Okay, yeah. And downstream target ERK kinase. But inhibition of GSK3 did nothing. However, somehow it's potentiate effect of nuclein. So, and downstream target CREB also was upregulated, but it was amazing. It was upregulated in both groups, even under nuclein treatment, when we upregulate P53, and then we reduce activity of GSK3. So, in a conclusion, what we see that both molecular active player in differentiation, but if P53 can affect on SOX2 and MAP kinase, GSK3 probably, of course, has some other target, but what we see, it has CREB as a target for playing with differentiation. So what we can conclude that both P53 and GSK3 have CREB as a main target, is a common target to just guide differentiation or proliferation in neuronal stem cells. So, thank you for attention, and I would like to say many thanks for my colleague in my lab, which also doing main work. So, thank you.
Thank you. And it was a
Do we have any questions?
complex.
Excuse me.
Yeah.
Yeah.
In your opinion, it looks like the PP3.
Here you go, sir.
PP3 is an antagonist to
GSK3, yes.
Have you guys checked it?
Yes.
Also, what about the P38?
I don't know.
Yeah, the question over there.
I mean, it's really amazing how many function P53 has.
Yes, it is.
So are there isoforms or post-translational modifications of the P53 that target specific question as specific functions or other functions?
Yeah, thank you. Yes, but I think it's really just based on post-transcriptional modification and in a direct just integration with other proteins like GSK3, you know, P53 can physically interact with many molecules. And this can change activity of even P53 or the others molecules. And you know, it's amazing complex how it can work. And also what I just amazed, why in even phosphorylation in the same site of P53 can cause two different effects. You know, if it's phosphorylated by, for example, GSK3, it goes to apoptosis, or by others, it goes to proliferation or other effects. It's really very interesting. And also that I read in some article that if genius is doing simple from complicated thing, then you study P53, it's doing, it's make fool of us, you know. No, it's just, it's a joke, of course, but you know, it's really interesting and amazing molecules.
Yeah. Thank you very much. Thank you. So now we move to the next presentation.
The theme of endogenous regenerative medicine from endogenous cells, and I'd just like to acknowledge my co-authors. A lot of this work was generated by my postdoc Shan Lee. From Montreal, you can see we have our campus on the top of the hill. Bone, it's a porous living material This shows a micro CT of subchondral bone, where you can see the porous architecture and mature bone that has the bone marrow and endosteum, which is the here are these cells that line the inner surfaces of the bone. And when bone is wounded, we know there are mesenchymal stem cells in the bone marrow that become activated. And here you can see the formation of new woven bone. There are two regenerative responses in damaged bone. One is to generate, with osteogenic induction, the formation of osteoblasts on the woven bone surface. They can build up off of a pre-existing bone. Or here what you see is regeneration of bone through cartilage formation. And in certain contexts, the bone will receive a chondroinduction signal, which allows the development of cartilage from the surface of the bone. And in this bottom figure, what I'm showing you is a healing osteochondral defect, where the bone has been stained with von Casa, which stains the mineral, the phosphate mineral. And here the toluidine blue is staining metachromatic glycosaminoglycan in the developing callus. So when bone is wounded, it will spontaneously regenerate through mesenchymal stem cells that differentiate to osteoblasts or chondrocytes. And the end stage, this cartilage will calcify and become bone. Actually, in some cases, the bone void is too big. This is what you call a critical size defect. And the tissue that repairs in the defect is neither woven bone or callus rise to calcified tissue. It can become a fibrous repair. And in fact, the part of the motivation I had for doing this project was someone I met at a Canadian Arthritis Centers of Excellence annual meeting. Her name is Francine, and she had had this pressure building up in her chin, and she didn't know what it was, and it turns out it was a tumor, and so they had to take out her mandible. It was an advanced osteosarcoma, and to repair that, they took her fibula. Actually, the most common repair for these things is they take your own bone and transplant it into your jaw. The graft took on one side, and she had a replaced mandible with her own bone. But on the other side, she had a non-union. This is a non-union. And they fixed it with metal plates. And at the time of the meeting, she explained to me that the metal plate was cracked. The bone was not healing, and she was pretty scared. She said, I don't know what's going to happen. And what we decided is, with the colleagues, is that really this kind of non-union could benefit from a kind of tissue engineering approach to help regenerate the bone. And the principal aim of bone tissue engineering is where you start with a wound where you're going to have some bleeding, and hopefully what you can do is replace that with a porous scaffold. And in the idea behind endogenous repair is that this endogenous scaffold is going to allow the ingrowth of bone. So you're going to get ingrowth of hopefully woven bone with, of course, this won't take place without invasion of blood vasculature, but eventually the porous material would be allowed to degrade. This is, of course, a cartoon. It's not what really happens in real life yet. But the bone is overtaking the porous implant that's degrading slowly over time, along with vascular invasion, and eventually would be replaced by living bone. So this is the real goal of bone tissue engineering, is to reestablish living bone. So one approach that actually a lot of people have been studying is the use of a bioplastic called polycaprolactone. It's a polymer created through that can have a variable chain length. In fact, it only melts under high temperature. You can use an approach with a porogen polyethylene oxide, which is biocompatible. And in this process, what we showed is that if you melt these two polymers together and then do this static annealing, If you let it anneal for a longer and longer period of time, you develop a pore structure that's controlled and the pores get bigger and bigger. So we could make porous scaffolds for these bone tissue engineering applications. And the next stage of the study was to proof of concept that these scaffolds could support bone differentiation. And to do this, we use an in vitro osteogenesis assay, and actually in 3 dimensions. But the normal assay is you seed mesenchymal cells, primary human mesenchymal stem cells from bone marrow on the surface, and after 10 days, they'll become confluent. And then you put the osteogenic medium, which contains dexamethasone, on the cells and let them grow for 3 weeks. You have to let them grow for 3 weeks because it takes about a week to start laying down collagen, and then another 2 weeks for the collagen to start mineralizing with the mineralizing enzymes and factors in the matrix. But what we found was, in fact, the PCL surfaces are quite hydrophobic, like any plastic. The cells don't spread or adhere to the plastic. And when we cultured in 3 dimensions, what we saw was that the cells will grow into the scaffold. Here, the H&E stain, you can see the pink stained cells, but there were very few cells actually growing on the surface of the scaffold. Here in S, they were mostly growing in the pore spaces. And when we did an alizarin red stain, we find that the mineral was only accumulating in areas where there were pockets of cells. So in fact, these scaffolds are not osteoconductive. They're not allowing bone growth on the surface. So there's a major challenge in designing surfaces of these porobioplastic materials for bone tissue engineering. We need an osteoconductive surface. That means that the surface allows cell adhesion, osteoblast differentiation, which leads to mineral deposition, and ideally, in the case of dental bone voids, the surface should resist infection as well. In fact, surfaces guide stem cell responses, and actually you can't really see very well here. This is the vinculin stain showing focal adhesions that are formed on a fibronectin coated plastic compared to just tissue culture plastic. So depending on the cell surface, the stem cells will spread and develop focal adhesions or spread and have different cell responses. So in this project, actually it was carried out in collaboration with a small biotech company in Winnipeg called Kane Biotech, and they developed a concept that you could fuse P15, which is a biomimetic peptide. Maybe you've heard of it. It's a 15 amino acid peptide that's derived from collagen type 1, and it can stimulate osteogenesis in vitro by mesenchymal stromal cells. And CSP is an amphiphilic peptide that actually is expressed by bacteria. And it's a quorum sensing peptide that has an isoside that's positively charged and hydrophobic. And this synthetic peptide actually has membrane perturbation properties. It can perturb the membrane and kill bacteria, and it can inhibit biofilm formation in a mutant form. So the structure of there's an alpha helix that has a cationic side and a hydrophobic side. So the hypothesis we tested in this study was that P15CSP, it's a novel fusion mimetic peptide, could have emerging properties that aren't shared by CSP or P15 alone when it's deposited as a coating, so the fusion peptide. In this study, we used a dry coating approach, which actually is more translatable to a medical device, because once you've tried dried coating, you can store it. It's stable at room temperature. So we simply filter sterilize the peptides and let them evaporate in the cell culture hood overnight. And this was allowing easier collaboration because we could simply ship the plates to Kane Biotech to perform the biofilm assays. And in this bacterial culture and biofilm assay, they inoculate with Streptococcus mutans And after 18 hours of culture, you can measure planktonic growth, that's the liquid phase growth, or biofilm formation through a dye stain. And then we use the same types of plates to look at osteogenesis. We analyzed adhesion, cell metabolism, and then we looked at osteogenesis using the traditional assay. So these are the results of the antimicrobial assay. And you can see by the bar in gray that the CSP showed a killing effect on the bacteria after 18 hours. That when we deposited mixtures of P15 and free CSP was more. The P15 CSP fusion peptide coating showed a decrease in biofilm formation, which you can see here, less biofilm on the surface of the well. And the free CSP was able to inhibit biofilm formation at levels that also inhibited planktonic growth. So this part of the study showed that the coating in fact inhibits biofilm formation without inhibiting planktonic growth. The free CSP coatings inhibited planktonic growth in higher concentrations, also inhibited biofilm formation. But the P15 peptide by itself had no effect. In our cell adhesion assay, we exposed the mesenchymal stem cells to the coated Petri dishes, and after 1 hour, the cells were washed off, and this shows a phase contrast where the cells stuck very well to the coated surfaces with CSP, P15, and fibronectin. There was an increased adhesion with P15, and after 1 hour, we see the cells have started to spread on the CSP, P15, CSP, and fibronectin surfaces, and not so much on the P15 and uncoated surfaces. After 24 hours, we see good spreading for these surfaces and a little bit less for the P15 and tissue culture plastic. When we performed a MTT assay, we see the uncoated P15 and P15 CSP are all cytocompatible, whereas CSP shows a slight cytotoxicity for mesenchymal stem cells. So this part of the study showed that the fusion peptide, CSP, and fibronectin accelerate surface attachment in serum-free media. And these coatings are cytocompatible and rapid restructuring of actin and spreading. In our osteogenesis assay, I don't know if you're familiar with the osteogenesis assay, but typically we use 2 markers to show differentiation of cells to osteoblasts. So the alkaline phosphatase is an enzyme that's used by the cells to generate biomineral. It degrades beta-glycerol phosphate to phosphate and glycerol. And alizarin red is a stain for calcium. And here you can see the deposition of a mineralized matrix when the cells are cultured on the P15 CSP coating, along with alkaline phosphatase stain in all of the wells. And you can actually elute the alizarin red and quantify it by absorbance. And this assay showed that the coatings with P15 and P15 CSP were able to increase calcification of the matrix in the presence of dexamethasone, and there was a higher average calcification with the fusion peptide. The next stage of the study, we were interested to see whether or not we could obtain the same effect of the coating on thin films deposited by plasma and enhanced chemical vapor deposition. It's also called PECVD. And the way this works is that you take a ethylene gas mixture and argon oxygen, and under a plasma polymerization, you can deposit 200 nanometer thick films, and we showed that these have 6.7% carboxylic acid content. We also generated thin films that were hydrophobic from hexamethyl disiloxane vapors, which were generated on tissue culture plastic. And the idea behind this was that the anionic surfaces these anionic hydrophilic surfaces could better retain the CSP peptide, the fusion peptide, through the CSP cationic isoside. Actually, at the time of the experiment, we thought that the hydrophobic surfaces may retain the peptide as well through the hydrophobic patch. But as I'm going to show you, it wasn't going to happen. So we characterized these surfaces through water contact angle. You may know what this is. It's when you put a drop of water on the surface, and if it's hydrophobic, like Teflon, the water contact angle is greater than 90 degrees, and if the surface is highly wettable, the water contact angle is less than 90 degrees. So actually untreated is tissue culture plastic, and your tissue culture plastic normally has been treated by normal plasma under CO2, which gives an anionic surface. And this has a water contact angle less than 90 degrees. The HMDSO has above 90 degrees, and the LPPEO surface is even more wettable. And when we culture MSCs on these surfaces, we find a very spindle-like morphology on the hydrophobic surface and a more spread morphology on the LPPEO surface. And I was just interested this morning at the who's the speaker? Affymatrix Shirley, yes, Dr. Shirley's talk, that perhaps the cells could be undergoing asymmetric division on this type of surface. So this is where we had a quite interesting finding on the osteogenesis assay carried out on the hydrophobic surfaces. The cells actually were able to adhere and proliferate and to express alkaline phosphatase. But after 3 weeks in osteogenic media, the cells have not produced any calcified matrix. And when we carried out the same assay on the LPPEO surface with the different peptide coatings, what we find is the cells have all expressed alkaline phosphatase and heavy calcification with LPPEO. And the quantitative assay, we see an enhanced calcification compared to the tissue culture plastic coated with peptide, and the best calcification was with the fusion peptide. So these results showed that all surfaces, with or without the peptide coatings, mesenchymal stem cells to differentiate to early osteoblasts by alkaline phosphatase activity, and hydrophobic thin film suppressed calcification, the biomineralization, with or without peptide coating, and that these P15 and CSP and P15 coatings on hydrophilic surfaces were able to enhance the biomineralization in osteogenic media. The study was limited by, in fact, we have only indirect evidence that this coating was stable, but we did have a reproducible cell response, which leads us to believe that the coating, we did demonstrate bioactivity of the coating, but there is a possibility some of the peptide solubilized during the assays and led to a combined response to soluble and immobilized peptide. So the conclusions of this study are that the hydrophobic surfaces, in fact PCL, like PCL, prevent MSCs from biomineralizing, and it may be because they cannot reach a highly packed density that you need for osteoblast function. The fusion peptide has properties not shared by P15 and not shared by CSP, so this fusion peptide does have emerging properties, and it may enhance osteogenesis by promoting cell adhesion or by promoting cell proliferation on hydrophilic surfaces. And I'd just like to acknowledge my collaborators at Kane Biotech, Mike Fertheimer, who does the plasma modification of the surfaces, Greg DiCrescenzo, who helped co-supervise Shan Li. Thank you.
Thank you for the very nice presentation. Is there any question? One over there.
Yes, sir.
Please.
Excellent. I'm just wondering. Yeah, I'm just wondering. Thank you. The fibronectin is adipokine. Do you have to think about what the mechanism underlying the fibronectin enhanced the mesenchymal stem cell attachment to the film?
Well, it's integrin receptor mediated.
That's when, the adipokine, normally mesenchymal cells can differentiate to adipokine. No, they release a lot of adipocytes, but release a lot of fibronectin. This is the reason I ask you, because we are run through the mesenchymal stem cell genesis. We found a lot of fibronectin. Actually, negative feedback inhibit the attachment to the plates, I want to say. So this is a mechanism we still don't understand yet. So I just wonder whether you have any thoughts of it.
Unfortunately, we didn't have fibronectin in our osteogenesis assay, so we didn't study that. Yeah.
Thank you very much.
You start the presentation with the three-dimensional culture, and then by the end you end with the 2D. So have you tried to scaffolds with this peptide and see if there is any difference in the results?
Thank you for your question. It's the paper is under preparation, and what we found was that the peptide won't stick to the PCL, and it was we just tried the dry coating on PCL scaffold, and I think the moment you put it into the tissue culture medium, the peptide just comes right off. So what we have recently published in Polymer is that you can actually do LBL on the PCL. And so what you can do is you can attach hydrophilic peptides onto the PCL 3D scaffold. And we did carry out osteogenic cultures on those scaffolds as well. So we're currently, the paper's under being written. Okay, thank you.
Okay, thank you very much. Thank you very much. So now we move toward the last presentation. Dr. Francisco Navarro. It's coming from Austria. And he's going to talk about transplantation of autologous bone marrow-derived stem cells for traumatic central nervous system disorders. So, looking forward to your presentation.
Okay, so I will try to go straight to the point before we get hypoglycemia. So I'm coming from Austria. Then I'm from Mexico, but I'm living now in Austria, and I find pretty much a relationship with stem cell research. Mexico City is actually like stem cell research. It's beautiful. Everybody wants to go there, but everybody is afraid of there. So talking about clinicians, it's pretty much the same. And Vienna is an appropriate environment to work about this. And it's nothing to do, but I'm so proud. This is my boy. He's 5 months old. Okay, taking into the point. Okay, so the situation I'm going to talk about this traumatic brain injury. As you may know, this is a high prevalent disease, and there's nothing that now there's no treatment that we can say, okay, this improved the outcome of the patients. About 5,000 people die every year in US, and furthermore than dying, the disability that this causes. So until now, as I said, no clear decrease in TBI-related mortality. The second important disease is spinal cord injury that is also highly prevalent. It causes it is also in young people, and there's nothing to do about it. And this is not exactly a traumatic disease itself, but it runs in the same line because of the method that I want to talk about, that is stroke. That it's also the leading cause of disability, of major disability. Just to make an idea, while we are speaking here, before we go to lunch, there's going to be 5 persons that are going to die in consequence of stroke or major disability. So these are theoretically preventable diseases, but we are not getting there yet. So we have to look for another option. And as I say, these treatments, the treatments approved for these diseases are not getting to the point. So in the treatment, you can do rehabilitation, a lot of physical, electronical, all kind of rehabilitations, and the people still have the disability. So no treatment with efficacy, not even in experimentation. So that's where we can apply the cells. So I have to say, I'm clinician, so we are skipping a lot of the basic science that you know better than I. So why we use autologous bone marrow stem cells? Because the secrete factors, and also because of the neuroprotection and the inflammatory suppression and the neural repair. But mainly, we want to highlight, as previous conference, that we are attending to this because of the neuroacute protection. That has to do with the secrete factors and to do with potentialized the normal functioning of the neural cells. So as we know, the systems are made to, when it's trauma, when it's an injury to the system, the cells are trying to get the best, to get lowered inflammation, to get healing as soon as possible. The thing is that it's not enough, our system, to do that, and then goes the consequence. Okay, so another thing that happens here is neurovascularization, transdifferentiation further in the therapies, neuroplasticity, etc. The advantages of autologous that there's no ethical or immune concerns, and is relatively easy process to harvesting these cells. So there's have been published papers about this with few patients, but basically in 2005 with brain injury, with improvement of the outcome. There was no comparing group. It was single trial with few patients, but it was made before 48 hours, after 48 hours of the injury. Then one subacute, after 1 month of the injury. And both of those show some a better outcome. Then we have in spinal cord injury also in acute. There's these 2 papers already published in acute patients that they are improving the score, and they are improving also in the motor function by different scales. Then someone made it in 3 groups, acute, subacute, and chronic. And as we can see, in the chronic patients, there was no improvement compared to the acute and subacute. And the most improvement was in acute patients. That was 2 weeks, after 2 weeks, in the range of 2 weeks of the injury. In a stroke, happens the same, and recently publications of the stroke and the influence of the inflammasomes that has to do with the injury and the post-acute injury that may be telling us that we are the right way. So why acute? Why acute? This is what we want to do. This is acute protocol of patients. We have been treated. So we have been treated chronic patients after years or after months of the injury. There's some improvement, but there's no the improvement that we want because several conditions. But basically, the method is very easy. All of us, I think we know. It's harvesting from bone marrow, about 200 cc's. it goes to a closed system that makes minimal cell manipulation. It's a simple separation by centrifugation method. It's important to say there's already one group that said about that this extraction, this aspiration in acute patients does not cause any hemodynamical disturbances. Then we can get about 8.5 million cells measured by CD34. And then why we measure this, because there's already publications about the correlationship with clinical improvement and the number of CD34 positive. And then what we do is we take these cells, we take the buffy cold, and then go back to the patient in about 25 minutes and to the cerebrospinal fluid. Recently, another publication about how the cerebrospinal fluid can influence in the transdifferentiation of stem cells into neurons. It's very important because, as you've seen, I didn't say that, but I've just seen these previous studies, they make intravenously, so they make almost the same process, but they inject it intravenously or intraarterially directly in the brain in the case of stroke. But maybe this can be a good idea to go also into cerebrospinal fluid. So lumbar puncture, it's a minimal invasive procedure. We have been doing that for a lot of decades, not me, but the people. And then it has not problem between the blood-brain barrier. When it's an acute injury to the brain, some studies have said that there's a disruption in the blood-brain barrier. Furthermore, if you inject, you overcome this part. But also maybe that these stem cells IV can help to reconstruct the blood-brain barrier. But we are still in that. So we have treated 61, I'm just talking about spinal cord injury, we have treated 61 patients with spinal cord injury. We followed them 6 months. The mean time since diagnosis was 72 months, so it was long after the injury. So that is a problem because the selection of the patient, even if it's acute, has to be very carefully because the patients with a big defect, it has no sense to treat them. Or the patients after several months they get syringomyelia, and there's no reason to treat them because such a big defect with such small number of cells, as you see, it's about 8 million. It's not a lot of cells. In chronic patients, there's not a lot of improvement. Even though we saw that 62% improve muscular strength, half of the patients and half of the patients improve spasticity. It has to do, it's correlated directly with the condition of the patients before, if it's complete or incomplete section, and if it's and how many CCs are of the defect. No patient had any side effects. That this is good to say, except for some headaches because of the lumbar puncture. Okay, so this is what we have done and what we want to do, and this is the study that it's running, and hopefully next year I can give results about this one. So it's safe, it's clinically safety. It can be because the system, it's small amounts of the technique. Yes, it has to do with the practitioner, but the process it's small, induced with human error, in a way of speaking. There's effectiveness in chronic patients, but it's not satisfied. When you have spinal cord injury, maybe it doesn't matter if you feel a little bit more, or if you can move and twitch a little bit more leg. It matters if you maybe can walk. So we think we're ready for a randomized control trial, and as soon as we get the grant, we are doing it. Then what we want to do in this time, because we want also to fulfill all the requirements of basics, to put also imaging to track stem cells. So this is not available. There's two papers about that, but it's in animals model. But this could be the way to say, yes, these cells are there in the defect, and these cells are maybe doing their job. And we just think that to be successful man and science does not need to be complicated. Also, simple solutions for complicated problems, and then in clinical field, sometimes simple solutions make a good effect. And this is our team, and that's it.
Okay, very good. Question 6. So,
93% of your people had a general increase in health. 93% of the people who had this treatment had a general increase in health. Can you just tell me what you meant exactly by that?
Yeah, it was a questionnaire. It's subjective feeling about after the transplantation. That's why I didn't put too much attention into that. Even if it's very good, it's important for the people to feel better. It doesn't give us any results about if it's working or not, because it could be the placebo effect. It could be that they just are doing better because of other consequences. But generally speaking, yes, 93% had these improvements, and it was a questionnaire.
Is it psychological, because they've received some treatment?
Yeah, maybe the placebo effect about they are getting stem cells and this is super treatment, so I feel better.
So something I think you could help us with, if you don't mind going back a few slides to your summary. That one.
Yeah.
Some of people here are clinicians, and so even though we understand that you're headed toward blinded, randomized studies, it would be helpful to get a sense of, for those numbers, what do you see in your practice when you haven't transplanted anyone? For the same kinds of, so for instance, you're saying that after the transplant for these 61 patients, 50% improved in spasticity. How many patients improve in spasticity?
Without.
Yeah.
Yeah, okay. Comparing, because we don't have a control group, we didn't do a control group, but if we compared,
historically,
we see historically groups, we have to separate the groups. But in a complete group, taking into account complete and incomplete is much, much less. So the sensibility is about 30%. The spasticity, I think it's about 40%. I don't have the numbers here, but the muscular strength for us was the most important sign that there was something going on, because normally with several treatments, with rehabilitation, the sensibility improves, and maybe I think there's a couple of studies that made the sensibility in 50%. But muscle strength, that means if in the chronic patient they overcome the long use in the muscles, so there's stem cells that are making reconnections between the neurons and the muscles, and hasn't been shown in any other studies about treatment with rehabilitation in spinal cord injury, I have to say. Yeah.
yes. Final question there.
I would like to see I'd like to see a control group of the same thing done with just lumbar puncture. Just to rule out that there's no systemic effect of getting a lumbar puncture?
Yeah, so there's a big study about 800 patients in Germany that they infused stem cells by lumbar puncture. I think 20% of the patients were kids, and there were no side effects. It was just to prove that the method, it wasn't doing, we didn't do that, but it was about, it's like 800 patients. So I think it's pretty safe.
Yeah, I meant more just whether the lumbar puncture itself causes muscular strength, systemic effect
Yeah. Okay. Thank you.
Here you go. One more question.
How much can you relate the symptoms to just intrathecal insertion of cells versus intravenous? I mean, you chose both, so there must be some studies where they create each route and its effectiveness on the symptoms that appear on the
Yeah,
positive
so
symptoms.
there's no study that make with the same sample both, one's IV and the other one's just intrathecally. I think that's what you mean. There's no such in the same study with the same characteristics of patients. But what has been described is that if it's chronic patients, there's no improvement about IV infusions because there doesn't pass the blood-brain barrier. So that has been shown, but not exactly comparing in the same group. But it is something we have to do, certainly. Thank you.
So before you all leave, just a quick announcement, if you will. Because we're running a little bit late, we'd like to have you back here in your seats at 10 after the hour, after 2 o'clock, 10 afterwards, okay? And those of you who are speaking in the next session, please come up and make sure that your talks are in the computer before you go to lunch, okay? Look forward to having you back in about 50 minutes or so. Thank you.
Okay, no. So, firstly, I would like to apologize because I will read my presentations, because for me it's much better to do my considerations reading that talking in English. Okay. Good afternoon. Initially, I would like to thank the Cell Science Meeting organizer for the opportunity to present my studies and my considerations regarding the potential impact of superoxide hydrogen peroxide imbalance on cell dysfunction, cancer, senescence, and regenerative therapies. As we know, the energy production by aerobic organisms involves oxygen and glucose, usually obtained from diet. The ATP is produced from several biochemical reactions that take place inside the mitochondria. However, about 5% of oxygen is transformed in superoxide anion, a reactive oxygen species. Dr. Boveris named electron leak the process that leads the superoxide production. As superoxide is continually produced, the cells have an endogenous antioxidant system to control the superoxide levels. This system involves the actions of superoxide dismutase enzymes that turn superoxide anion into hydrogen peroxide. Further, hydrogen peroxide is catalyzed to other by catalase or glutathione peroxidase enzymes, depending on each cellular compartment. We also have an exogenous antioxidant system, which involves molecules usually obtained from diet rich in fruit and vegetables. The cellular control of superoxide anion and hydrogen peroxide concentration is considered crucial to the cell because at a low concentration, hydrogen peroxide can work on intracellular, whilst at right levels, its molecule can cause cellular dysfunction and senescence. Therefore, alterations in this antioxidant equation can trigger oxidative stress that is related to risk of several chronic diseases. Previous epidemiological investigations reported associations between a genetic polymorphism located in SOD2 gene with several chronic degenerative diseases. These genetic variations is known as 16-val gene SOD2 gene polymorphism. SOD2 is a nuclear gene located in chromosome 6. Initially, it produces an inactive SOD2 protein that contains a mitochondrial target sequence, which triggers the SOD2 protein inside the mitochondria. And this organelle, SOD2, becomes an active enzyme. In human beings, the Al16-val SOD2 polymorphism changes an alanine amino acid to valine 16 code. These substitutions cause a change in SOD2 protein structure, and for this reason, ALL presents 40% high SOD2 enzyme activity. Therefore, AA genotype is able to catalyze high concentrations of superoxide anion and hydrogen peroxide when compared to VV genotype. However, this region did not affect the levels of glutathione peroxidase enzyme. As a consequence, it triggers increase of hydrogen peroxide levels. So the excess of hydrogen peroxide cross over the mitochondrial membrane and react with metal ions such as iron, producing hydroxyl radicals that cause genetic instability and increase the risk of cancer. Differently from AA genotype, VV genotype has been associated with metabolic diseases, and it produces a beta-sheet SOD2 protein that is partially arrested to mitochondrial membrane. For this reason, VV carriers present high levels of superoxide anion that react with nitric oxide, producing several oxidative molecules like peroxide nitrate that cause lipoperoxidations and cellular dysfunction. Our previous investigations showed associations between VV genotype with high oxidized LDL levels, hypercholesterolemia, obesity, inflammatory biomarkers, and all regulations of SOD2 gene expression in young subjects that performed intense aerobic exercise. Further, we observed high immunosenescence biomarkers, high DNA damage, and high breast and prostate cancer in AA subjects. Two results found by us were particularly intriguing. Although we have found association between AA genotype and high breast cancer risk, a complementary study performed in women with breast cancer showed that VV genotypes present high risk to develop metastases after chemotherapy. This result was also described by other authors as Dr. Christine Ambrosoni from Canada, who performed a prospective investigations of women affected by breast cancer undergoing chemotherapy. This author reported that VV women with breast cancer present higher mortality risk than AA carriers. These two studies have played an important role in the focus of our current research performed by my lab, which now investigated the effect of superoxide hydrogen peroxide imbalance on specialized cells such as lymphocytes, adult stem cells, and cancer cells. In order to study the impact of superoxide hydrogen peroxide balance on cells, we established two in vitro experimental models. The first one involves the use of pharmacological drugs that cause superoxide hydrogen peroxide, whereas the other ones involve the study of human cells carriers different A16 Val genotypes. In our pharmacological model, we use paraquat as a superoxide donor, porphyrin as a SO2-like molecule, and sodium nitroprusside as a nitric oxide donor. We also perform investigations involving Brazilian plants that present SOD2-like or glutathione-like compounds. In our in vitro SOD2 study, we firstly genotyped 200 subjects. After that, we selected a subsample with similar lifestyle, ethnical, and social demographic characteristics. These volunteers were invited to donate more blood sample to perform in vitro protocols. Before blood collections, we asked the volunteers to avoid the consumption of antioxidant and supplement foods in order to decrease the potential interference of environmental variables. The mononuclear cells are both obtained and maintained for 24 hours in the same cultures to uniform the oxidative conditions. We also use the same model to analyze the adipocyte stem cells now. Afterward, the cells were submitted to different treatments. Just a minute. So far, we performed several studies using in vitro SOD2 experimental models. The main results show that this polymorphism has potential toxicogenetic, pharmacogenetic, and nutrigenetic effects, as we can read from these studies published previously in the literature. We also investigated if this polymorphism could affect the cell senescence. Previous studies performed by our team observed that, in general, AA presents higher proliferative rate than VV cells. However, an unpublished study suggested that rather than VV cells are able to maintain its proliferative capacity. In this case, VV cells tend to present the telomerase gene epiregulated in 6-hour cultures and in 15 days cultures than AA and AV cells. These studies are in consonance of previous investigations that observe high immunosenescence biomarkers in AA cells when compared to VV cells, and with studies that observe resistance of VV cells to expositions of anti-inflammatory drugs. We also analyzed the effect of superoxide hydrogen peroxide imbalance on cancer by using our pharmacological model. Preliminary results suggest that pharmacological agonists of VV and AA genotypes are able to induce apoptosis of colorectal cancer cells. After 24 hours of expositions, both paraquat and perforin caused cell mortality. This effect was similar to observed on cells treated with oxaliplatin, a chemo drug. Just on the feet. This study also showed the influence of superoxide hydrogen peroxide imbalance over the response of colorectal cancer cells to oxaliplatin. Cells concomitantly exposed to oxaliplatin and high superoxide levels from paraquat presented high anti-proliferative rate than cells treated only with oxaliplatin or treated with perforin. These results reinforce the relevance of superoxide hydrogen peroxide imbalance on proliferative and apoptotic control of cancer cells. We also believe that superoxide hydrogen peroxide imbalance and not only hydrogen peroxide could have an important effect on adult stem cells used to tissue, to potentially use it to tissue regeneration. Generally, mesenchymal stem cells are in low number in body tissues, and for such a reason, these cells need to be expanded in vitro before the transplantation to regenerate damaged organs. However, for several times, this process can lead to cell senescence, result in declines of differentiation and of proliferative capacities. The evidence obtained from both animal and clinical studies show that there are the major concern about the mesenchymal stem cells implantation. Recent investigations published in the literature have suggested that the modulations of hydrogen peroxide can play a role in vitro mesenchymal stem cells proliferation. However, some authors consider controversial the use of the hydrogen peroxide to induction of proliferative stem cells, because this molecule can cause DNA chromosomal instability. I started performing out in my, okay, just a minute. I studied performing in my lab by Machado showed that despite a hydrogen peroxide exposition triggers cell proliferation of adipocyte stem cells, also cause important DNA damage. And this result is relevant since we don't want to introduce in our body cells with chromosomal instability. The genomic damage can inhibit the differentiation process and turn to cancer. We also performed a complementary study. Of effect of food with SOD2 activity, like in the stem cells, and use the guarana, richest fruit used in energetic beverage supplements here in the United States of America and in another place. And we observed that this extract can modulate differentially embryonic stem cells lines exposed to high levels of oxidative stress. A recent study performed by our team also observed that the supplementations of antioxidant compounds in cells after 7th or 8th passage can to decrease the senescence markers that is generally observed in this phase of the culture. Using senescence adipocyte stem cells derived from human lipoaspirates. By taking into account the results produced by our research, by our investigations published in the literature, we believe that superoxide hydrogen peroxide balance or imbalance plays an important role in the cell biology and have a pleiotropic effects on cell proliferation and senescence, mainly in stem cells. Therefore, our results highly highlight the relevance of superoxide hydrogen peroxide balance, and not only hydrogen peroxide, as published in this moment in the literature, on cell biology. And we believe that concomitant management of superoxide and hydrogen peroxide level could be an important tool to improve the safety and the efficiency in the general stem cell regenerative therapies, considering that metabolism, oxidative metabolism, is general for all cells. Thank you very much, and please apologize because I have so difficult to speak here. Okay, thank you. Okay. AA present an intermediate production of dismutase enzymes. We believe that in the ancient times, everybody was VV genotype, or human beings. So human beings have low levels of SOD2 activity. The A that present a high SOD2 was fixed in the human populations, and now perhaps 6% of population have a AV, heterozygote genotype, that is a balanced SOD2, and about 16% have a VV genotype that present high levels of superoxide anion, because the enzyme is less efficient, and another one's AA. AA, risk with cancer. VV, risk of metabolic disease. It's very interesting. Heterozygotes have the half alpha helix protein, SLD2, and half beta sheet protein. So have a middle in terms of cancer. Well, Christine Ambrosone, for the first research that published the association with AA allele, two alleles with high cancer. AV, no, AV is good. And we published some studies involving the associations of VV genotype with hypercholesterolemia, and obesity, and other groups, research groups, have published the associations with diabetes complications like nephropathies and retinopathies with this genetic polymorphism, because SOD2 is considered a lethal gene, because if you don't produce SOD2 enzyme, we die. It's impossible. Okay. Thank you.
Check the level of expression.
Level expression about I don't know if I understand you. If we check the level of the
expression, you have a polymorphism.
Yeah.
But this allele, depending on the people, can make a certain amount of enzyme depending on how it is expressed.
Yeah, well, yes, this check was performed by other authors previously, about 20 years ago, using knockout gene knockout mice that measure that, for example, AA genotype have 40% higher SOD2 enzyme efficiency than VV. And we also measure the levels of these enzymes.
Activity or expression? Sorry.
Expression and activity. Expression, okay, sorry, sorry, because for me sometimes it's very difficult to understand. Yes, we measure the gene expression using RT-PCR. Okay. Okay, very much.
Thank you, doctor.
Our next speaker is Dr. Rafia S. Al-Lemki, and she's from the University of Cambridge, and she'll be talking about TNF modulation of cancer stem cells and renal cell carcinoma.
Thank you. Yeah. Thank you for the introduction. Can you hear me? Thank you very much for the introduction, and thanks for to the committee for providing me the opportunity to speak today and discuss my data with you. For those of you who are unfamiliar with this field, I'd like to give you a brief introduction. So tumor necrotic factor, otherwise known as TNF, is a cell signaling protein, and we know that it's involved in mediating cell death and inflammation in various diseases and cancer. It was, the story really started about 100 years ago when a doctor by the name of William Coley, he actually gave tumor patients some extracts from bacteria, injected them, and then he realized that not only did it regress the tumor, but it actually caused a huge systemic reaction. And then years later, Dr. Lloyd Old, who was then the father of modern immunology, in 1975, he actually identified the same molecule in his supernatant of endotoxin-treated macrophages. And then his colleague Carswell, what he did is injected mice with a BCG endotoxin, and he realized that actually the mice produce serum factor that causes hemorrhagic necrosis of the tumor. So from this time onwards, it was thought that maybe TNF has some sort of part to play in tumor, in cancer research. So how does TNF exert its biological responses? Well, it binds to two cell surface receptors. These receptors show sequence homology on the extracellular matrix, but they're unrelated in the intracellular domain. They they don't have an intrinsic enzyme activity within the cytoplasm. So the way the signal cascade occurs is through interaction with adapter proteins within the cytoplasm. And depends on what the trigger, they can actually cause apoptosis, proliferative genes, inflammation, or survival. But then the thing is they can actually trigger individual molecules, or they can trigger the same molecules, and therefore they show both shared and non-identical signaling pathway. So why are we interested in RCC, renal cell carcinoma? Well, 2% of these represent adult cancers worldwide, and of the 2%, 90% of them are kidney cancers. And out of those 80% of the clear cell type. Now, these cancers are very important in a way that they've drawn a lot of attention because they show very poor. They're resistant to treatment with the radio and chemotherapy, and they originate from the tubular cells within the kidney. They're known to secrete TNF, and I've myself reported this in 2010. So that shows that TNF may play a role in the initiation and progression of the RCC, mainly the ccRCC. So a few years ago, in 2010, we set out to actually determine whether these receptors are expressed and whether they actually function in the ccRCC. So what we've done is, on the left is the H&E, just showing the morphology. I term here a normal kidney as non-tumor, just a non-tumor zone.
and obviously the different grades of RCC. There are normally 4 grades, but I only show 3 here. And on the right-hand panel is immunofluorescence of that we've labeled with anti-TNF-R1 and R2. And what we show that in normal kidney or non-pathological kidney, R1 is constitutively expressed in the glomerular and vascular endothelial cells, while R1 is actually rarely found in normal kidney, and if so, very maybe infiltrating cells. Whereas it's opposite in the RCC, whereas you have upregulation of TNF-R2 and mainly localized to the tumor cells, and as well as infiltrating cells. And at this point in 2010, we thought that actually R2 is expressed, these infiltrating cells are actually mononuclear cells. R1, on the other hand, is only found in the vessels and in some of the infiltrating cells. So then my interest was, okay, well, that's actually an observation, but actually what we need is to look at to gain insight into the tumor and find out what exactly do these receptors do. So what I did is I've developed myself an organ culture system in our laboratory, whereby I take pieces of tissue less than 1 millimeter in diameter, or rather, in diameter. We place them in culture. And then what I did is through our collaboration, my collaborator in Belgium, we altered a bit of the wild-type TNF sequence so that we can actually substitute the amino acid to bind to either TNF receptor 1 or TNF receptor 2. Thereby, we can delineate which of the receptor is signaling. So we can maintain this tissue in culture, prime them with this mutin or the wild-type TNF for 3 to up to 18 hours. We then harvest the tissue, fix it and stain it. And what we find here that when you ligate TNF-R1, you actually induce cell death of these cells within the tumor. And when we did co-staining some of these were tumor cells. And can I use the pointer? Yes. It's pressing, you know?
It's right here.
Yeah. So we use tunnel staining to detect apoptosis versus the caspase-3, and we find that wild type triggers cell death. One, which is R1 selective mutant, triggers cell death as well, but R2 doesn't, and this can be shown on the right with a histogram. And then the opposite happens when you selectively ligate TNF-R2, you actually induce cell proliferation, and more so with the wild type in R2 as opposed to the R1. And again, it's significantly, there's a significant difference, more so with the wild type than the R2. So then the question became what are the targets of TNF in RCC? So we know that we saw that those TNF-R2 expression in some mononuclear cells. So there's a lot of literature now coming out that stem cells are actually that are present in RCC, and we know that they form a bulk of the tumor. They are tumor-initiating cells and have limited capacity for self-renewal. We know that they can generate any cell type. They're quiescent, slow cycling, and divide very infrequently. Again, they're very resistant to chemotherapy. That most of the chemotherapy targets cycling cells. So therefore, that's why we get recurrence of tumors. So now we know that maybe these cancer stem cells could be, the sensitivity could be enhanced by inducing them to divide. So, so this is what actually leads me to my hypothesis, is to test whether cancer stem cells, that if we drive them to proliferation, can we basically, by ligating R2, can we render them more susceptible to cytotoxic agents? So what we did here, we first again looked at normal versus tumor. We use CD133 as a marker, as it's been proposed as one of the stem cell markers. And what we find here is RCC has more CD133 expression or expressing cells, and they actually increase with tumor grade, more so as the tumor becomes more severe. And then we know that they're actually stem cells because they express some of the stem cell transcription factors. In here I just show OCT4 as one of them. And then the other question becomes, well, can TNFR2 has any effects on this CD133? So what we do again in organ culture, I took the tissue with R2, R1 or the wild type. And again, I see that when you selectively ligate TNFR2, you increase these numbers that, of cells that express CD133. And interestingly, that these cells actually that correlates to an increased expression of the R2, and they are the ones that show proliferation by phosphohistone staining, which is one of the markers for proliferation. So then, the other question that was, can we actually isolate these stem cells from their kidney tumor? And so what we did is we used this is a technique that's out there. It's a MAX technique, it's magnetic activated cell sorting. So what you do is you cut pieces of tissue, you digest it using this dissociator, and you pass it through, you label the cells with the magnetic beads that have CD133, and then you incubate them, pass them through a magnetic column, and you get positive selection of CD133 positive cells. So, so these are actually stem cells that come from the tumor. So what we did here is a phase, just to show you a phase contrast image showing the morphology of the cells. On the right is immunofluorescent with CD133 marker staining. They show stem cell markers or stemness markers, but they don't actually show any differentiation markers. So from this time onwards, we know that actually we are dealing with stem cells. And then we wanted to find out, do these actually express TNF and the receptors, but in culture? So again, our at 3 hours and 6 hours, hardly R1 or wild type is detected, but actually the increase in time, especially TNFR2. This is just a representative image of the results. On the right is the relative mRNA expression with the qRT-PCR. Again, that's the treatment on the x-axis. When you treat with wild type, R1 or R2 ligation, you increase TNF message, while the opposite happens. When you ligate R1, you increase TNF R1, and ligation of R2 increases the TNF-R2. So then we wanted to find out what happens then if you prime these cells with an R1 mutant or the wild type of the R2. And what we find is, again, using tunnel staining as a detection for apoptosis, wild type and R1 increases death of these cells, and more so at 18 hours than 3 hours. And some of these cells that are dying are actually showing expression of TNF-R1. That's the opposite happens when you ligate with R2. You actually increase cell proliferation of these cells here in pink, and we use phosphohistone as a marker for cell proliferation. And again, these cells express TNF-R2. So here, the flow cytometry results were concordant with our immunohistochemistry, but in this instance, we use proliferative cell nuclear antigen as a marker for cell proliferation. And again, you get the shifts on the right with the R2 mutant and the wild type, but not the R1. So then the next question becomes, well, okay, so we know that the R2 receptor can actually be transcribed. It can be induced by both the protein and the mRNA. So the next question really is, can we actually prime these stem cells or with the R2 to drive them to cell differentiation and towards the epithelial phenotype? And the reason we are interested in epithelial phenotype is because RCC is actually a tubular epithelial cell tumor. So we were interested, so we used a 3D matrigel. And again, on the left are the treatments and the days in culture. And you see that actually there's spheroid colony formation in day 2. And there's an outburst of cells, day 4, day 7. In R2, they start forming network-like structures. And then in day 14, you actually get like a tubular-like formation. And interestingly, you get simultaneous loss, actually, of the stem cell markers or transcription factors, but you don't actually lose OCT4 and Lin28. And this wasn't actually very surprising to us, because we have previously reported this in a a model of myocardial infarction, which I'm not going to go through, but I'm happy to discuss with anyone who's interested after. And then, interestingly, you start getting induction of differentiation marker, more so cytokeratin, which is a epithelial phenotype marker, and APCAM, that epithelial adhesion molecule. And the thing is, you start gaining TNF-R2 in these tubules, and TNF, not so much of R1, hardly there. So then, what really clinically, it's relevant, but really, what clinical trials, I think what would be interesting is, now the thing is, we know that stem cells are resistant to chemotherapy. So can we actually drive them to proliferation, to make them more sensitive to anti-cancer agent? So what we did here is we took, I'm just showing a simple data really, is to take the cells, the stem cell that have been isolated from the tumor, treat them with we use cyclophosphamide here, by the way, because it targets the cell cycle. So what we did is, and sorry, this is actually used in the clinic, so we wanted to try it in the laboratory. And what we did is we took the cells, either untreated in media only, treated them with R2, or the cyclophosphamide on its own, or drive them to cell cycle first, and then treat them with cyclophosphamide. That's actually the lower one was what we were interested in. So this is actually just flow cytometry data, really, Hirsch just to show the nucleus pattern and an axin for apoptotic and necrotic PI. And you see that when you drive them to proliferation by R2 first, and then treat them with cyclophosphamide, you drive them to proliferation, kill them, and they actually show more effects of the chemo drug than when actually you use the chemo drug on its own. So really, in summary, we know now that our stem cells, cancer stem cells in CCR can be studied in situ and in vivo. We know that when you ligate TNF-R2, you can increase proliferation of R2, its transcription of R2 itself. You can promote these cells to enter cell cycle and differentiate into tubular structures. We also know that when you ligate TNF-R2, you can render them highly sensitive to an anti-cancer drug. And overall, really, our results show that TNF may provide an important signal for differentiation of CCR6 cancer stem cell, and that could maybe be exploited in the clinic, really, for killing and eradicating tumors. Thank you for your attention, and I'm happy to take any questions. Or just to say, this is Cambridge, by the way, in summer. Everyone, this is like one day in the whole year. And that's the famous King College. Thank you.
I have a couple questions. Excellent work.
Thank you. Thank you. Thank you.
And one is you showed that the TNF receptor 1 is selectively expressed in endothelial cells, and selective activates TNF receptor 1 cause cell death.
That's right.
Is that the tumor cell dying, or is other cell type? It didn't show.
Well, predominantly were tumor cells.
If it's tumor cells,
yeah.
Have you thought about why you activate TNF receptor 1 on the endothelial cell surface and cause tumor cell death?
Well, I think that is something we can do, but that's not the direction we wanted to take. So we were actually... No, that's a very good point. I think we should, because, I mean, there's a lot of angiogenesis in RCC.
Because that's, you can use tumor necrosis factor to actually kill the tumor cells through endothelial cells.
Yeah, you can, but our target was the stem cells, because they are the ones that keep the tumor going, you see?
Yes. And the second question is about the cancer stem cells.
Mm-hmm.
You showed that actually in the RCC cancer stem cells, there are expression of 4 so-called pluripotent stem cell transcription factors.
Right.
LIN28,
OCT4.
NANOG, OCT4,
and NANOG.
And yes, SOX2.
Right.
And we know that false expression can induce pluripotency. So
Right.
convert that to a pluripotent stem cells. How
Right.
about, can you culture your so-called stem cells in culture infinitively as like a iPS
A bit like
cells, or
iPS, yeah.
they'll die eventually?
No, I think you can, but I don't think
Do
that
you-
would be
do
our.
you-
That's not our direction. But
Okay.
maybe it's possible. But the problem then becomes is you see when you deal with tissue, it's totally different to dealing with a
Isolate these
single.
cells, right? You isolate cells by the magnetic sorting.
That's right.
Okay. How about
Yeah.
the behavior of these cells in culture?
No different to any other cells that we've
They
used the
eventually
MEC
die.
system.
They eventually die, right?
You mean on it once you isolate them?
Isolate and put in culture.
No, they don't. I think you lose a lot of them, but they don't
They are
die.
differentiated or?
You have to drive them to differentiation. In my drive, yeah. Nice question. Thank you.
Other questions?
We have one more question right here.
Mhm.
Sir?
It sounds counterintuitive that you are growing the cancer stem cells and trying to kill them then. So I think a clinical question is how efficient you are. Because if
You mean in killing them?
in killing them, exactly. Because
think,
if
you know,
if you kill just a percentage, you end up with the same amount of cancer stem cells, which is not good, of course.
Well, that's a valid point, but I think at this point we need to test a bit more drugs to be able to say whether if we are able to tune to which drug we cannot kill all of them. I mean, the thing is, the whole point of the experiment really is because we know they're chemo-resistant. And we know that in clinical, that's why the drugs fail in the clinic. And the question then becomes, is instead of using TNFR1 to just directly kill them, because then it's probably there'll be an adverse, probably inflammatory reaction, then maybe the best way to do is go indirectly and say, well, can we actually sensitize them so that they can respond to the anti-cancer agents?
Then maybe just a quick question.
Yeah.
You don't have to answer this.
No, it's fine.
How much reversing can you create by removing the receptor activation? Can you reverse?
Well, okay, so I didn't show the data here, but as I said previously, I actually published a paper on how important when R2 is. For example, when we take a mouse and we knock down TNFR2, you have a reverse effect. You don't have lots of stem cells, and you don't have any effect at all. So there is a way where you can maybe reverse it by manipulation of the receptors, but that's something we've never done in this model. So we don't. I think there's a lot we can do.
Yeah. Thank you very much.
Yeah. Thank you.
So thank you.
Thank you very much. Thank you.
Our next speaker is Mei Wang from Johns Hopkins University School of Medicine. And she'll be talking about mobilization and differentiation of multipotent Nestin-positive stem cells during arterial remodeling.
Okay, it's a great pleasure to present our recent works here. So as a long-term research interest, my laboratory has been trying to understand the mechanism, how mesenchymal stem cells are involved in tissue repair and remodeling. And as we know that bone marrow mesenchymal stem cells were initially recognized as skeletal stem cells that give rise to osteoblastic lineage of cells and contributes to bone formation during skeletal development and bone remodeling in adults. So now we know that mesenchymal stem cells exist in many tissue. But bone marrow is still considered as a main home of mesenchymal stem cells. So if we look at this diagram, this shows the localization of mesenchymal stem cells in bone marrow. And this is a piece of bone. We can see this is the osteoblast bone surface. This is bone marrow. The mesenchymal stem cells mainly resides at the outer space of this bone marrow sinusoids as a perivascular cells. Previously, because there's no single specific marker to label this population, and the MSC population were prospectively identified by using sets of cell surface markers. Here are at least 3 sets of surface markers that are commonly used to analyze or isolate MSCs from bone marrow. So my laboratory, this is the marker we commonly use to isolate this population from bone marrow. And in recent 5 years, actually, several single markers have been identified that can mark a subpopulation of MSCs in bone marrow. So, for example, in 2010, Paul Furness group and from Albert Einstein Institute, what they found is the bone marrow cells expressing nestin that have the ability to renew and multi-differentiate, has a multi-differentiation potential. And they also, this nestin positive cells in bone marrow constitute essential HSC niche component. So they think that the nestin positive cells in bone marrow represent a subpopulation of MSCs. So, like other stem cells, the MSCs have, as I said, has multi-differentiation potential. They give rise to a spectrum of mesenchymal cells, such as osteoblasts, adipocytes, and chondrocytes, myocytes, so on and so forth. And so, because of these features, the MSCs are considered as injury drugstore. So whenever there's an injury, there's a tissue injury or any system has a disease in a disease condition, these MSCs can be released from their original niche, such as bone marrow, and mobilized to the blood circulation and to the injured or diseased sites. So far, there are 2 fundamental questions that to be resolved in this field. One question is, how can the MSCs mobilize or migrate to the target sites in response to tissue injury or in disease conditions? And another question is, how can, if this mesenchymal stem cells can recruit to the injured sites, how can they commit or differentiate into specific local cells to participate in tissue repair and remodeling? So, so this the the goal of our studies try to, for long term, try to address these questions. So in this project, the model system we use is arterial injury model of mouse and rat. So the reason we use this as a model, because I consider myself as a bone biologist. I'm not a vascular biologist. So initially we use this model because we think that the artery has a very simple structure, and it contains mainly 3 layers. The innermost layer is intimal layer, mainly contains endothelial, just single layer endothelial cells. And in the middle is called medial layers, made of smooth muscle cells, and the outermost layer is the adventitial layer, is actually connective tissue. So another reason we use this model is after injury, actually, is, in the mouse or rat model, there's if we do the endoluminal injury, that is the whole endothelial layer is damaged. So after that, almost every animal develop, this. This is pathological vascular remodeling. This is a new intima formation. Now it is clear that these new intima cells are alpha SMA positive smooth muscle-like cells or myofibroblast cells. More importantly, this arterial injury model just mimic the clinical restenosis after coronary angioplasty. So if there is a blocked area for this coronary artery, usually the doctors put a catheter inside and with a balloon. And then once the balloon is inflated, so the lumen of the artery is opened up. And then the balloon can be removed and then left a stent there to keep the artery open, so the blood flow is restored. So one of the problems of the treatment is in 6 months, about 30 to 50% of the patients develop this restenosis, which pathologically is the new intima tissue formation. During the past several decades, regarding the origins of the new intima tissues, there are intensive studies. However, the origin of the cells are still controversial. So classically, it is believed that this new intima cells are derived from the medial layer of vascular smooth muscle cells and adventitial fibroblasts. So these local vascular cells can migrate to the injured sites and then form new and proliferate to form new intima tissue. And another opinion is because there are resident vascular stem cells or progenitor cells, so these cells also involved can migrate to the target sites to contribute to new intima formation. And in recent 10 years, I would say, more and more evidence indicate that the circulating or stem cells or progenitor cells involved in this process. Initially, we try to confirm whether mesenchymal stem cells can migrate to the injured sites to contribute to new intima formation. So here we use the rat model of balloon insertion-induced injury in carotid arteries. So this is the sham control. We can see 1 week after arterial injury, we can see that a very thin layer of new intima is formed here. And at 2 weeks, that's the thick new intima tissue is formed. And then we detect whether MSCs can be detected at the injury sites. We use nesting as a marker. We can see in the sham control group, we did not detect any nesting positive cells. However, at 1 week and 2 weeks after injury, we see a single layer of nesting positive cells, which shows green here. So just a single layer at the intraluminal side of the new intima tissue. And we can see the deep layer. This is a new intima formation. The new intima tissue in the deep layer, we cannot see nesting expression. So we thought the nesting positive cells, once recruited there, they differentiated into the myofibroblast or smooth muscle cell-like tissue, and then they lost the nesting marker. So I will show you more evidence later. So actually, due to the time limit, I will not show you all the data. We use different MSC markers to detect. We got the quite similar result. And then what we want to test whether these cells are from derived from the migrated from circulating blood circulation, and then we detect the nesting positive cells after arterial injury in mouse, and we found that at 3 days to 2 weeks, nesting positive cells in blood significantly increased compared with sham control group. We also detect the MSCs using this 4 surface marker. So this MSC exhibit a similar pattern. So at 3 days to 2 weeks after injury, MSCs significantly increased in the blood circulation. And then we want to see whether these nesting positive cells, whether once they recruited there, whether they contribute to new intima formation. So we use this lineage mapping mouse model. So by crossing the nesting promoter-driven Cree mice with the ROSA 26 EYP mice. So in the offspring of these mice, all the nesting positive cells and their daughter cells are labeled by this EYP fluorescence signal. So that means all the nesting positive cell derived cells we can detect using the EYP fluorescence marker. So we can see this is sham group and 1 week, 2 weeks after injury. So in sham group, consists with previous result, we did not see any EYP positive cells. And at 1 week or 2 weeks, a lot of green cells we can see in the new intima tissue. And then we counted the EYP positive cells. About half of the new intima cells express EYP. That means half of the new intima cells are derived from nesting positive cells. And then the next question we've asked is, what is the mechanism? What is the that induce the MSC mobilization, migration to the target sites? So this is what it is proposed. Cell-involved tissue remodeling. So once there is a tissue injury and the injury sites, the injury tissue will produce pro-migratory factors and then locally form a gradient to induce the migration of the cells to repair or remodeling the tissue. And on the other hand, the factors can also infuse into the blood circulation. A high concentration of these factors may induce the mobilization of the cells from their original niche to the blood circulation. So the question we asked is, what is the pro-migratory factors in this situation? Okay. So then we developed the ex vivo transval assay. What we did is we isolated the aorta from rat and then cut it open and make in the luminal injury. And then we cultured the uninjured vessel or the injured vessel. We collected the conditional medium. So and then we placed the condition medium at the bottom layer of the bottom chamber of the transval and MSC on the upper chamber. And so the purpose is if there is any factors released from the injured vessel, so this will induce the cell migration. So as we expected, only the injured aorta condition medium induced the migration of the MSCs. Here's the quantitative data. And then, so I just cut the long story short. We detect a lot of factors in the condition medium, and finally we figure out is the TGF-beta 1 is the factor in the condition medium that induce the migration. Because if we add the TGF-beta neutralizing antibody, there is almost a block the migration of MSCs. So this is another piece of in vivo data. We inject the mice with inhibitor of TGF-beta receptor 1, and then totally block the nesting positive cells recruitment at the new intima tissue. And then, so we also identify the downstream signaling molecules. We found that TGF-beta through activate SMAD signaling pathway and promote the production of one, which is chemoattractant. Promote the production of MCP1 in the injured tissue, and the MCP1 can mediate the migration of MSCs. So this is we just inject the antagonist of MCP1 receptor and also block the recruitment of MSCs. So just summarize this part. So what we found is in response to arterial injury, TGF-beta is released, and then the active TGF-beta 1 in turn promote the production of MCP1 and induce the migration of the cells. So and the next question is, after the cells recruited there, do they differentiate into myofibroblasts to form new intima, or they differentiate into endothelial cells for repair? So again, we use this mouse model. What we found is this is the uninjured control, and the green cells, which is nesting derived, positive cell derived cells, and we can see majority of the cells expressing alpha SMA. That means majority of the nesting positive cells differentiated into new intima myofibroblast, but none of them differentiate into endothelial cells. And then we also did differentiation assay using the condition medium, which I mentioned previously. What we found is actually TGF-beta 1 also has multiple functions, and one function is induce migration, another is promote the differentiation of the cells into myofibroblast. And then we identified that we use different inhibitors of beta 1. TGF-beta 1 can stimulate different signaling pathways, and we find out that RHO-A signaling pathway is mediate TGF-beta induced MSC differentiation. And finally, we used a specific RHO-A ROCK inhibitor called Fosdel, which is an FDA-approved drug. We treat the mice with Fosdel for 4 weeks. What we found, surprisingly, not only the new intima formation is inhibited, and the cells, the nesting positive cells, differentiated into endothelial cells. So that means the RHO-A inhibitor treatment divert the differentiation of MSCs away from myofibroblast into endothelial cells for repair. So this kind of in vitro assay. So due to the time limit, I just summarize what we found is so the MSCs contribute to the new intima from the pathological arterial remodeling, and TGF-beta released from the injured sites can regulate 2 different action modes on MSCs. One is induce the migration of MSCs through SMAD MCP1 signaling pathway. Another function is to promote the cell's differentiation by inducing RHO-A, by activating RHO-A signaling pathway. So blocking RHO-A ROCK signaling pathway, so the MSC differentiate into endothelial cells for repair. And right now, we are trying to figure out the downstream molecular basis for why, so underlying this phenomenon. Okay, I just want to acknowledge all the people who contribute to this project. The lab postdocs or graduate student, and this is our collaborators. Thank you.
Thank you. So, in the interest of staying on time, we'll have to let you take questions afterwards. Okay. Thank you. All right. So, our next speaker is Hanna Dobrowolska, who is coming to us from Columbia University Medical Center, and she will be discussing increasing the engraftment capacity, oh, this is great, and function of hematopoietic stem cells after transplantation.
So I would like to present today the way of increasing the engraftment capacity and the function of hematopoietic stem cells after transplantation. As we know, stem cells are the only one cells in the organism which can self-renew and in the same time differentiate toward of the lymphoid lineage, as well as all the cells from the myeloid lineage. So we are talking here about all the granulocytes, monocytes, platelets, and erythrocytes. Hematopoietic stem cell is the cell which is also responsible for the renewing the process of hematopoiesis after all the cells are destroyed during the myeloid or immunoablative procedure, which is the procedure used mostly for preparation patients for the transplantation. Hematopoietic stem cell is differentiated by the number of markers. It's mostly CD34 positive, as well as CXCR4 positive, CD20 positive, CD90 positive, CD117, which is known as a c-KIT. The CXCR4, known as well as CD184, is the transmembrane receptor, which is present not only on hematopoietic stem cells, but also on all hematopoietic progenitor cells. It is receptor for SDF1. SDF1 is a stromal derivative factor which is secreted by bone marrow stromal cell, and it's the strongest hemoattractant for hematopoietic stem cells. So, hematopoietic stem cells, which are CXCR4 positive, migrates toward the SDF1 gradient, and it's forming the axis CXCR4-SDF1. This formation is responsible not only for the migration of hematopoietic stem cells, which we observe in the process such as homing, which is a process during which the cells migrate towards bone marrow after transplantation, but unfortunately also SDF1 is secreted by other organs, and here we are talking about the metastasis process. This axis is also responsible for the stem cell survival, the proliferation, and also for the normal hematopoiesis. Talking about hematopoietic potential of the cells, we are thinking first of all about their potential to migrate towards the SDF1 gradient, but also their potential towards proliferating and renewing the hematopoiesis after the transplantation. This process we can check during the assay of hematopoietic colonies, and in my experiments I was interested in growing colonies from one of the myeloid compartment, I was concentrating on the progenitors of the white, which differentiate towards granulocytes and monocytes. This is the example how the colony looks like. So hematopoietic stem cells and progenitor cells, which is the material used for transplantations, can be obtained from bone marrow, nowadays more often from mobilized peripheral blood, but also from cord blood. And a lot of factors such as anticoagulants, temperature, storage time, but also the knowledge of the personnel who is preparing the cells for the transplantation are responsible for cell survival, but also for the ability to proliferate and reconstruct hematopoiesis after transplantation. Although there is no one standardized procedure of storing and preparing these cells among the transplantation centers in the world. So the aim of my study was to evaluate the influence of the most common used anticoagulants such as EDTA, CPDA1, which is the most used in England, and the heparin, very common used anticoagulant from 1950s. The temperature of 4 degrees Celsius and 37, and different storage times. The cells which were not stored at all, they were stored for 1, 6, 12, and 24 hours. I was checking how these factors will have influence on the migration of bone marrow stem cells towards the gradient of SDF1, the ability to create hematopoietic colonies. As a material, I used the mice bone marrow and the methods which I was using. So I collected the cells from femur bone from mice, and then I divided them for different. Each groups were stored with different anticoagulants, EDTA, CPDA1, heparin, and the control group, no anticoagulants at all. And they were stored during 1, 6, 12, and 24 hours in temperature of 37 degrees Celsius or 4 degrees. I also had the group of fresh collected cells which weren't stored at all. All these groups were moved towards the hemataxis assay, which is the assay which show us how many cells are able to migrate towards the gradient of hemoattractant, in my case SDF1. The cells which we graded, I divided and I made a group of the cells which I want to check how many cells migrated. I done that by using the flow cytometer. And the second group was used to start the clonogenetic assay. So the first method, hemotaxis. For this method, I've been using the plates, 24 wells, transwell plates. Each well in this plate includes one insert. Insert divides the well in the two compartments, upper and lower. Each insert has the porous membrane which allow the cells to migrate from upper compartment when we put the cells in medium towards the lower where we place the medium with chemoattractant, in my case SDF1. And then we can check how many cells migrated. So all the groups were put into this experiment. This is the movie. In which you can see how the cells are migrating during the hemotaxis assay. These are all the cells put on the upper compartment on the well. and one more, which is showing the single cells now, which is migrating towards the gradient of chemoattractant. So with the pipette, we are placing the chemoattractant, and we can see how the cells is migrating towards the gradient of this substance. And I have to go back to presentation. Yeah. Sorry about that. I need to show you the results.
Okay.
So you already got this right here. There you go.
Thank you.
Thank you. So this graph is presenting the results of the chemotaxis assay, which was done on the cells which were stored in the 4 degrees Celsius. So here we have the percent of the cells which migrated towards SDF1, and this is the storage time for how much they were stored, all the groups. The single lines represent all the groups which were incubated with anticoagulants, EDTA, CPDA, and heparin, and the control groups, no anticoagulants. We can see that all the factors like storage time and also temperature and types of anticoagulants have influence on the number of cells which were migrating towards SDF1. We see the trend of decreasing and increasing the number of cells which were migrating, and the 6 hours seems to be a peak where the almost 30% of the cells migrated. The more interesting seems to be the 37 degrees Celsius, which we have similar graph, percent of migrating cells, the storage time, and different groups of anticoagulants. Also, the cells are decreasing and increasing towards the time, but also 6 hours seems to be very interesting, where the anticoagulants such as heparin and CPDA seems to be the best. When we compare with 4 degrees Celsius, we can observe that almost 60% of cells migrated comparing to 30% in 4 degrees Celsius. The second test, which I performed, was a collagenicity test, where I grew the colonies towards the monocytes and granulocytes. I used the hematopoietic progenitor cells, which I culture in vitro, and I push it to differentiate towards granulocytes and monocytes using the GM-CS factor and interleukin-3. As a colony, I set up the number of cells 50, the group of 50 cells. Let's look at the 4 degrees Celsius number of CFU-GM colonies versus storage time. So, similar pattern, similar 6 hours storage time, but the number of colonies is not that great. So here we have 37 degrees Celsius. We have 6 hours of storage of the group of cells with heparin seems to be the best condition for storing the cells which are getting ready to be transplanted. It's not only the number of the colonies, it also matters how the colonies looks like. So here we can see on the pictures that cells stored with the heparin during 24 hours, 12 hours, 6 hours, and 1 hour in the condition of 4 degrees Celsius or 47. We can say that 37, the colonies looks much bigger and better, but the best again, 6 hours, the colonies have the biggest size of all. So after knowing that the heparin, it will be the best anticoagulant, 6 hours of storing the cells, and also 37 degrees Celsius, I was interested to see if the concentration of heparin can matter versus the number of the growing colonies. So I tested 10, 20, 50, 100 and 2000 units per milliliter, and I look how many colonies I can grow. The best, it seems to be the 10 unit per ml, and the same 37 degrees Celsius. I move forward and I ask myself question, where the purest colonies, the pure monocytes and pure granulocytes can grow the best, in which condition? Of course, using now heparin and 6 hours of storage time, I compare 4 degrees Celsius and 37. It looks like the pure monocytes and pure granulocytes colonies grows better in warmer condition. My conclusions. Ability of hematopoietic stem cells migration and the creation of the granulocyte and monocytes colonies in vitro depends on type of use, anticoagulant, temperature, and the storage time. Heparin, it seems to be suggested anticoagulant for bone marrow stem cell preservation. Bone marrow cells, which are preserved in 37 degrees Celsius, demonstrated better migration response and proliferative potential towards granulocytes monocytes colonies. Higher migration and also number of colonies I noticed in 6 hours of storage. Number of migrated cells and colonies was changing periodically during 24 hours bone marrow storage. And I think that the stem cell migration capacity towards SDF1 should be the standard test in transplant quality evaluation. Thank you for your attention. Thank you.
Do you think that some of the effect might be due to the fact that heparin allows the cells to be in a medium with calcium? Because the other factors would deplete calcium.
Yes, that's true. That's how the EDTA and CPDA works. They bind the calcium. So this might be the difference because heparin is just inactivating the during the coagulation system. Yeah, that's the very good suggestion. That might be due to this as well.
I have a question. So cool, I have to ask a question. So the image you showed, time lapse, where you have this gradient, you have this single cell chasing it around. Have you looked at it with multiple cells? So if there were 3 cells there, do they interfere with one another? Is there any competition for the gradient? I mean, you have 4 cells in the local environment.
I mean, the hemataxis assay takes 3 hours, so that's kind of enough time for the cells which were supposed to migrate. They will migrate towards. Of course, there is a competition, but they are able to squeeze one by one towards the pores.
So a related question, the membrane itself, what effect might it have? Not all pores are created equal.
The pores in my membrane are equal.
I'm sorry. Different membranes which have different pores could elicit a different cell physiology.
True, but
yeah, I'm just speculating, is there an effect there?
So I chose the membranes which had the 3 micrometer pores. You can choose different types of the size of pores in membranes. And I chose the size because we know that the hematopoietic stem cells are the size of the small lymphocytes, which is around, it might be up to 4 microliters, so they are 4 micrometers. So they are able to squeeze through that pores. If we choose the pores which are bigger than the size of the cells, then almost all the cells might migrate. That will not be our answer to the questions.
Are you sure about that?
Yes.
We'll talk after.
Okay. Thank you. Thank you very much.
So our final speaker for this mid-afternoon session is Dr. Wendy Weston from 5X Biomedical in the U.S., and she's about the RNA profile of exosomes. No, she's going to have a different talk.
They changed it, but not on the printed one yet. I would have loved to have talked about that. That is
the community. And I want to share with you a few aspects, how we do it at our company and what type of quality we can provide. So we have started out in more than 15 years ago providing synthetic RNA for diagnostic applications, for high quality RT-PCR assays, essentially to detect viral RNA, and in order to provide that, we had to undergo ISO certification, and now we are also at the level of CGMP compliance, and we have really a fairly wide customer panel in the application of in vitro diagnostics for synthetic nucleic acid products, but the application in the mRNA field is really growing, and I think some of us, or most of us even, may have noticed a few press releases in the recent months, and also the involvement of the Gates Foundation promoting mRNA application and mRNA research. So in order to prevent this tool to the general community, we want to be a provider that offers these tools. The general approach is to create your gene of interest, which will encode it, the mRNA in a plasmid, combine it with a T7 promoter, and also combine it with a poly-A tail, so that after plasmid linearization, you can generate synthetic mRNA, which is carrying a cap that can be introduced during transcription or post-transcription, and it also should contain a fairly long and, importantly, free poly-A without any additional nucleotide. So you need some specific restriction enzymes, for instance, SAP1, which cleave next to their recognition site. So this is the recognition site, but the cleavage is really in the poly-A tail itself, so that not a single extra nucleotide is present in the poly-A tail, which is known really to be very important for mRNA function. And then, of course, the length of the poly-A tail is important, especially if you go to pharmacological applications where variability in your compound is not acceptable. And then, of course, the SAP1 recognition site, okay, it's 7 nucleotides, but you still have a rare chance that it will be present in your gene sequence of interest. We actually recently had one incident where a customer was asking for a specific sequence, and so you cannot use it. And if you use restriction digestion, you always have the problem that your cleavage is never 100% really, and a small amount of uncleaved plasmid template will generate very long transcripts, because you have essentially a circular template, and the termination is not at a specific site, so you will have just poor or variable background that you can poorly control. And our standard approach is actually use the cloned plasmid, but we do not include a long poly-A tail, because that's also not stable in proliferation in E. coli. We just have a short oligo-A sequence, and we use PCR. In that case, it's indicated with M13 primers, but the actual primers that we use could be different. But the enclosed between the primers, so present in the PCR product, we have the T7 promoter, we have, of course, the gene sequence of interest. And then due to the use of a HEAL primer, which contains the long oligo T-stretch, which encodes exactly the size of the poly-A tail and hybridizes via a gene short stretch at the 3' end. We generate a PCR product which generates a defined poly-A tail. It has a free poly-A end, and it is not limited, of course, by restriction sites. And also the PCR product that we generate as template can be analyzed in reliable fashion, and you don't have the problem of backbone background from the plasmid. For that, of course, we need fairly long PCR primers, and here I showed just back as an example, so that these fairly long DNA oligos now with advanced chemistry, which is available from some suppliers, can be really obtained in high quality, so that the desired quality of the PCR product is possible. And then, of course, we have two important steps: PCR for the generation of the template and the in vitro transcription reaction, actually to convert the template to synthetic RNA. And not in all cases is working very well or more or less ideal. Here in an electropherogram, we see the desired full-length product, and we see a fairly large amount of smaller products which are due to premature termination, that the polymerase stops before it reaches the real end of the template. And we have modified the IVT reaction conditions, so starting from here, we could get to this type of quality, which is fairly reasonable. Another example is essentially also changing the IVT method that we use. And in another example, which looks even worse than the other two, we were working on both steps, new PCR approach and new IVT, and also in that case, we were not satisfied until we have reached a fairly good quality of our IVT RNA product. This is just the general workflow. So we start with the chemical synthesis from a service provider, and we get a cloned plasmid product, where we make sure that the insert is really 100% what is asked for. Here you see the PCR product and the quality control by capillary electrophoresis. And then we use that for in vitro transcription, and then of course we can introduce cap with cap analogs, also by post-transcriptional capping. And also at this step, it's an easy thing to replace standard NTPs with M5C or pseudo-U, which are known to reduce the immune response, which is important when you want to generate induced pluripotent stem cells. And it's important that we really have only RNA, so that the template DNA has to be removed reliably, which we also confirm by RT-PCR analysis. And after purification of the transcripts, we analyze them also with capillary electrophoresis. You have seen examples before, and this is actually comparing the slight mobility shift that we have observed if we go from completely unmodified RNA transcripts with the trace showing in red to fully modified, which contains cap plus the internal nucleoside modifications. We get to this blue trace. And this is the workflow, how we have established it in the lab. Just that we have also several control steps, which we call internal process controls, and finally QC before we release it. And also to share with you some properties. Of course, the standard is to determine concentration by photometer, and this is complemented also by at least small quality control measure with 260 to 80 ratios, but this is also not so widely used and also reached in the community or the different commercial suppliers. And then we combine it with capillary electrophoresis to determine the size, and it's also complementing quantification because the photometer is very dependent on RNA conformation. So in order to recognize obvious deviations, the capillary electrophoresis is based on a different quantification measurement. Then we check for bioburden tests so that our RNA preparations show no growth on bacterial or fungal media, and that also the endotoxin level is below determined amounts. We make sure that protein is absent, that we have RNA only, so that it's completely digestible with RNAs. And as I said already before, we make sure that no template DNA is left over with a potential risk of gene integration into the genome. And we make sure that we really work with the proper sequence. So when the incoming plasmid is analyzed, we want to make sure that there was no mix-up. The final product is analyzed again, that we show it has to be what it should be. And then we also make sure that we have a pure sequence. So if we produce several products for the same customer in parallel, we make sure that if we have 6 different products, product 1 contains nothing of the other 5. And really on a very sensitive level with RT-PCR detection, where we can detect contaminants in the ppm range. And now I come to the conclusion. So this is the type of procedures and products I wanted to share with you.
Great, thank you.
Here you go, sir. Here you go.
That resulted from the transcription regulation. Can you transfect these RNAs like we transfect DNAs into the cells? And what is the efficiency?
It's actually better and easier, because if you want to do DNA transfection, you have to get your nucleic acid into the nucleus. Whereas the mRNA, you only have to go to the cytoplasm. So with several transfection agents that our customers have tested, they found it much easier and more efficient than DNA.
And the length of life, how long it is? Sustained.
Yeah, okay. So you have the length of the poly A tail you can play with. Then you have your untranslated regions before the translation start, and after the translation start, the actual sequences that you have in these elements can influence stability and the stability that has been reached, so that you have a half-life of about 24 to 36 hours.
Thank you.
Other questions? I have one. Not in terms of specific names, but can you give us an idea of who are your customers, and has the profile changed over, say, the time that this technology has been available?
Well, we are asking or answering specifically to the messenger RNA. We have started that only 3 years ago, and And the hype has also started about 1 year later. So the change in the customers is that we have pharma customers, and also big pharma customers coming into play, and that also industry in general steps in, investors step in, as I had mentioned. It also has come to the to the knowledge and recognition of the Gates Foundation, so that this technology should be available to a wider base of customers. And we have three key players working on the mRNA technology, two actually in Germany and one in Cambridge, near Boston. But they are very advanced. They produce mRNAs in high numbers, but they only do it in-house. So no customer from outside can get the product. And there are only really very few auctions where a customer can come to a provider and I have this sequence, can you do it for me? And do it in GMP compliance, whatever is needed. And that gap we want to fill. And we have customers from pharma, but also from universities, and also startup companies. And then the goal always is, okay, produce us non-GMP quality in the beginning, but we want to get high quality GMP grade material also finally, so can you do that? And then it gets the options get very few.
Thank you.
Okay.
Our next speaker is going to share with us about extracellular matrix-assisted cell viability. He's Christopher Bradley, Biologics in the U.S.
Thanks. So yeah, I'm here representing Lattice Biologics. We're a Scottsdale firm, and we are known for producing, we're a certified tissue bank, and we produce tissue allografts for all sorts of applications, including surgical intervention, as well as we have dermis tissue products. We have tendons for sports medicine injuries. And I want to talk a little bit about extracellular matrix-assisted cell viability, because we, as a tissue bank, want to step into the stem cell space and bring a new generation of allograft, tissue allograft, improved healing. So here's an example of some of the bone allograft material that we currently have in our product line. Allografts are kind of our business. A lot of these are derived from cadaveric tissues and are used in spinal fusions and orthopedic surgeries. Usually is a void filling, wound healing approach. They're decellularized, and even some of them are demineralized, like the cancellous block here. And I'm going to talk mostly about bone, because it's something that's kind of the first mission of ours, is to improve upon our bone allografts. So maybe it's just wishful thinking, but hopefully sometime in the future, it'll be just as simple to repair a human being as it is to repair a car. And so we envision that we could play a part in this and provide parts that would be superior to existing technologies. The gold standard for, say, bone healing is to autograft, which would be tissue from the patient that is taken from a donor site. There are complications with that, and with tissue morbidity and difficulty with the second site healing. So allografts are the next best answer. Now, we're focused on extracellular matrix because we think that's kind of an approachable technology that we can derive from stem cells that would provide a number of different signals that could accelerate the healing process. So you see all of the cues that a pluripotent stem cell can respond to, or not, in the case of quiescence. But as stem cells have the capacity to self-renew and differentiate, they can also apoptose. And so we would like to use what we know about the extracellular matrix to stave off apoptosis and wake up cells from a quiescent state so that they can both proliferate and differentiate and engraft onto allograft material and become a new standard of care. So the extracellular matrix is rich in all sorts of protein signals, and soluble factors are also present in the milieu, which we don't intend to dissect and identify in any sort of rigorous manner. We just want to use control extracellular matrix that's available, but that from stem cells that could aid in the healing process. With an eye on the future of eventually creating the ultimate allograft, which would be autologous, have better regenerative properties, faster surgical recovery. And some of the steps along the way to get there would start with our traditional allograft material. Here we have a bicortical dowel allograft, which we would intend to impregnate with native extracellular matrix, growth factors, maybe cells, adult stem cells, which are derived from adipose tissue or bone marrow or something of that nature, that have been grown under optimized, an optimized nutrient medium composition to encourage the right kinds of signals and to give the best proliferative capacity. So these are the burning questions that are driving our strategy right now to our next generation allograft development. And I include the Phoenix Sun here, which I miss after only 2 days. We're in Scottsdale, but it's part of the Phoenix metro area, and I haven't seen snow for 5 years. So I'm already missing the Phoenix sun. I was wearing shorts 2 days ago. So the burning questions driving us right now, one would be, how do we define that culture media that will enhance propagation and promotion from isolated stem cells? How to enrich for stem cells and promote healing in transplanted allografts? And then finally, how do we wake up those stem cells once we've derived them from tissues? So to answer the first burning question, or at least to address it, we're developing technologies in collaboration with the academic lab group at Montana State, who are modeling fluorescent chimeric RNA aptamers. This is kind of work that is based on the Jaffrey Group's technology, those of you that know about spinach. And the idea here is that these RNA can mimic three-dimensional protein-like structures, and you can select for these RNA molecules from a library using CELEX. Now, the process for making a chimeric RNA aptamer is to do this kind of selection process, but in our case, it's going to be two different RNA aptamers that are joined together, one of which has been selected to bind a fluorescent dye, and the best example of that would be the chromophore for GFP, whereas the other domain has been selected to bind a metabolite. And then those two RNAs are stitched together, and they can be expressed in vitro in induced pluripotent stem cells in order to basically screen for the right ones. And the right ones should give off a fluorescent signal when they've identified and bound the target metabolite. So this is a really powerful technology, we feel, that could help us optimize nutrient composition of media that we would grow stem cells in. And we would look at levels of RNA or levels of metabolites, related metabolites, using different colors of chromophores. So you can have, you could look at the balance of a certain metabolic pathway and determine whether your cells are going to be optimized for transplantation. So that's the idea behind the development of this technology, that we can multiplex and that we can bind metabolites, not necessarily protein. So here's a good example of the applied technology. The balance of glutathione in its reduced state and in its oxidated state, there's GSH being the reduced state, GSSG being the oxidized state. The balance is important for the readiness of cells for transplantation. A high redox balance would indicate a more proliferative, undifferentiated state, and a lower redox balance would be more indicative of a differentiated state. So this is one example of a pair of metabolites that we would analyze using the chimeric RNA aptamers. We would measure the fluorescence output using a multispectral imager, fluorescence microscopy, and be able to tweak our nutrient composition to see the effects of certain nutrients that we put in the media on readiness for transplantation. And now back to the ECM, and I guess this addresses the second burning question, which is how do we get those cells to engraft onto the allograft? And so the idea here is to use ECM generated from stem cells. It's a complex milieu shown here with cell surface proteins like integrins and fibronectin, recognizing components of the basement membrane or the ECM, which provides a number of signals which can direct the stem cells towards migration, proliferation, or differentiation. So here's some of the approaches that you'll find in the literature. And the simplest being to grow cells in a monolayer in tissue culture plastic. Those stem cells then deposit their ECM, and you can then decellularize the tissue culture surface and recycle the ECM that's been deposited. And what we intend to do is actually transfer this onto a scaffold coating. There are some folks, some groups that are developing ways of growing stem cells on the scaffolds. We think that's a little beyond us. There's so many issues of perfusion and shear stress and bioreactor conditions. We think that a better approach is to simply transfer the ECM that's been deposited on tissue culture plastic and move it onto the scaffold later. So the main idea is that we want to exploit the ECM for its potential as a reservoir of signaling molecules, and not as concerned with the functions of tissue structure and cell adhesion, although those apply here, because the reservoir of signaling molecules that the ECM provides in fact, can instigate cell proliferation or a homing response, cell migration, or differentiation. Now, in the case of differentiation, let me remind you that our decellularized bone allografts already contain or retain bone morphogenic proteins. So the decellularization process is not stripped it of all of its instructive potential, but differentiation is kind of the endpoint, and we would like to encourage vascularization and attachment to the allograft prior to those cells choosing their fate. And we're encouraged by what we see in the literature. This is a group, DeCaris produced this work at UC Davis, and he and his group optimized the conditions for in the media in which they would test the ability of a decellularized matrix that was laid down by the stem cells in tissue culture flasks for their ability to stimulate osteogenic differentiation. So it appears that normoxia is actually the best for giving that kind of response, as shown by calcium deposition here. But on the flip side, hypoxia, we believe, is actually an important parameter that you can manipulate, or the oxygen tension, you can manipulate it, and hypoxia would then favor proliferation. So here's some more evidence from the literature. The first one I already talked about, actually, it's this one right here by DeCaris' group, that showed that the alteration of environmental culture conditions during matrix deposition affects the capacity of decellularized matrices to modulate self-fate. The other thing that DeCaris showed, which is really pivotal, is that you can homogenize and transfer these decellularized matrices, and they will retain that same osteogenic differentiation potential comparable to the native matrix that was laid down. Now, there's another group in San Antonio which does some really exciting work. This is Chen's group, and they showed that bone marrow ECM that was laid down actually extends the proliferation potential of stem cells that are laid down on the decellularized matrix. And probably most excitingly, when they compared ECM from a young donor compared to that from an older donor, they found that the young ECM had the ability to restore the functional capacity of those cells, the cells from older subjects, and they would act young again. So if there isn't a better argument for the fountain of youth in a bottle, I think we found it. So this is work that I did back at UC Davis's Center for Healthy Aging, where I was looking at chondrocytes from rat. And as I mentioned before, the ECM is important for adhesion and attachment. There's also, this is kind of to make the point that the ECM is a source of ligands for integrins. And we were looking at fibronectin, full-length fibronectin, against two different alternative domains, the V region, the 3-10 region. We were able to show that when we were measuring global and this is by uptake of radio-labeled methionine, we showed there was a stimulation in cells that were attached to fibronectin in its various domains compared to the same cells that were kept in suspension. So this shows that waking up idea, third burning question, how do you wake up these stem cells which may become quiescent, especially if you're culturing them in vitro prior to transplantation? How do you wake them up? Well, you may have to have the right collection of ligands that are recognized by their cognate integrins. Now the chondroprogenitor cells, same, this is the parental cell line for the previous one. The RCJ 3.1 cells, they actually act a little bit differently when exposed to the same ligands. And V and 310 give a partial stimulation, but full-length fibronectin gives an even more robust stimulation of global translation. Now, I don't have the same suspended control here. What I did in this experiment was I laid down polyL-lysine. Now, polyL-lysine will get the cells to attach, but this makes the important distinction that although you get attachment of your MSCs, you may not get the same kind of stimulation of global translation unless you are binding stimulatory or binding integrins that activate stimulatory signal transduction pathways. And so if you look into the literature, you will see that there's a small but growing body of work that discusses the integrin-dependent translational control. And I come from a translational control gene expression background, which is where I did my graduate work at LSU Health Sciences Center in Shreveport under Robert Rhodes. And now here we see that those three different fibronectin ligands, I should say, that were put down, actually are recognized by different heterodimers or different integrin pairs. So the 310 region is recognized by alpha-2 beta-1, full-length fibronectin by alpha-5 beta-1, and then the V region, alpha-V beta-3, but they feed into different pathways or similar pathways, ultimately impacting the translational machinery, which gives the go-ahead to start producing protein. And I think looking at the translational side of things could be kind of a key to understanding what would shift cells from a quiescent to a more active regenerative state. And then finally, DeCaris, again, shows that he actually identified alpha-2 beta-1 as the cognate integrins that bind the transferred decellularized matrix that they did the proof of concept in. And however, this was looking more at osteogenesis, which we're also interested in, as well as encouraging proliferation. And he followed up by looking at some of the flux through some of the signal transduction pathways that impact translation. But interestingly, there's encouraging bits in the literature that shows that not only do some of these stem cell derived extracellular matrices encourage proliferation or differentiation, but in this case they can stimulate or prime cells to be more responsive to bone differentiation signals. So this was RT-PCR. They followed the gene expression levels of 2 different proteins that are involved in bone differentiation, and basically showed that the ECM gave a more robust response. The cells grown on ECM as compared to tissue culture plastic. And so this is kind of our goal, is to tap into a synergistic approach to bone healing. And a former colleague of mine, Nadia Kornieva, also at LSU Health Sciences Center in Shreveport, showed that by engaging alpha-6 beta-4 integrin, the translational control pathway would be specifically upregulate the VEGF, which is important for vascularization. And coincidentally, BMP2, which is a bone morphogenic protein, and VEGF have been shown to have a synergistic effect on bone mineralization. So we think we're barking down the right pathway. And so we plan to adopt this strategy as we move along to develop our next generation of products. And that is to use existing decellularized allografts that we generate, alter the growth conditions of mesenchymal stem cells to produce custom ECMs, and that would encourage integrin ligand expression of our choice, and would also encourage vascularization. Thirdly, we would incorporate these ECMs, we would transfer them onto the allograft, and then produce these next generation allografts with superior healing properties, which should include better engraftment and retention of stem cells. And those retained cells should be primed for proliferation. And then from the signals already inherent in the allograft, differentiation could proceed for the appropriate tissue, and healing times hopefully would be accelerated. So we are also actively reaching out to anyone who feels that they out a study, a collaborative study on this same kind of thing. And we're both looking for folks who feel that the ECM is where it's at. So please do ask me any questions afterward, and I'll take any questions you have now.
Actually, we won't be able to take any questions now, but I'll take up on what you said before, which is Monument Cocktail Hour.
All right.
Which is coming up soon. Thank you.
Okay, thanks.
Okay, so our penultimate talk today is from Dr. Shahu Lee, who comes to us from Rutgers State University in New Jersey. He's going to talk about CREG1, how it interacts with SEC8 to promote myocyte differentiation.
Okay.
Okay. First, I don't want to be recorded. Okay. And I'll try to be short. And okay, my lab studies
differentiation of hypoxic niche bone marrow-derived autologous mesenchymal stem cells for retinal disorder treatment.
Good evening. Thank you, Mr. Sari. I'm the last in the session. Maybe I will share about the potential differentiation of mesenchymal in hypoxic niche for retinal disorder. Maybe this is a simple presentation. As we know, there is a chief area for personalized medicine. One of that is cell engineer. And there is our center in Surabaya. There is collaboration three institutions: School of Medicine, Dr. Sutomo Hospital, and Laboratory Stem Cell. And there is our roadmap in the clinical trial. We make a focus on safety, efficacy, and side effect. And there is a continuing of the roadmap and becoming clinical trial in the file disease. And there is our center in Indonesia, Surabaya. There is a beginning in the 1990 with a Pun Bank at Dr. Sutomo Hospital. And as we know, the stem cell have a basic cell with plasticity and self-renewal ability to differentiate and proliferated. So with the promising of stem cell, one of that is to treating of degenerative disease in here, like diabetes, myocard, stroke, and also maybe Alzheimer. And approximately, as we know, United States alone, approximately 128 million individuals would benefit from stem cell treatment. So MSC itself, there is cause of multiple capacity, so the tropic with a potent immunosuppressive effect and ability due to vascularization, and the utility to treat a large variety of pathologies, including retina disorder. So if we talk about retina, so it's very important we know about the embryology of retina. From the hierarchy of cell, so retina is developed from neuroectoderm of the prosencephalon. So this encephalon become optic groove, optic vehicle, optic cups, and becoming the retina, optic nerve, ciliary body, and iris. So the anatomy of the retina should be coming to many layers. In here, so we focus in the disorder and retinitis pigmentosa, as we know, is might be related genetic disease. So usually, generically, I describe a progressive cause of visual loss, which attribute to loss of fiable of photoreceptor, especially root and cone photoreceptor, and associated also pigmentary changes in the retinal pigment epithelium. So will the patient have a visual loss. So the photoreceptor that predominantly the effective might be root and cone photoreceptor and epithelium cell. And given there is a primary root and cone dystrophia, so the patient with central vision is separated lesion and loss of the vision. So there is maybe anatomical root cone photoreceptor in the pathway of the light perception in the patient. And there is retinitis pigmentosa with pigmented of the eye. So with analysis based on that, based of embryologies of retina from ectoderm, so need stem cell can develop to 3 germline. Usually mesenchymal stem cell is developed only 2 germ layer, ectoderm and endoderm. But because the embryogenesis of derm, so we need to manipulate change mesenchymal stem cell to pluripotent, which needs manipulation. Stem cell manipulation, stem cell have passed through 2 conditions before transplantation. The first from isolation in vitro condition, and the second in vitro manipulation when the cell before transplantation. Usually we can manipulate the cell in vitro environment. Some of kind is with hypoxia manipulation. So as we know, a stem cell needs can be determined by compartment composed of cellular and acellular engraftment. So become the control of rate of stem cell proliferation and determine the fate of stem cell ductor, and also protect the stem cell from exhaustion and death. So in here to focusing. Usually when to higher concentration, so approximately 5 or to 10 times more the concentration of O2 in the natural niche from organ in the milieu in the body. So as we know in the body, so usually the oxygen concentration for lung parenchymal is need 4 to 14% as circulation, liver and kidney. So in the brain, usually less of oxygen concentration, 0.5 to X%, as we know of eye, bone marrow, and adipose tissue. So there is regulation transcription for hypoxia condition, so make HbH hydroxylase increasing. So the regulation transcription for HEF1 alpha deposit and translate for gene to express glucose transporter and also HD8, PKD1, and chemokine receptor 7 and 4, as we know is important for metabolism, as we know is important for migration, and as we know from angiogenesis. And also the suppression of mitochondria, so lack of oxygen make releasing of ROS, and there is enlargement of telomerase, and also DNA dimate protection, and also inhibit of senescence and aging. There is for migration. So hypoxia condition make maintain proliferation, plasticity, genetic stability, and increasing of enhancement of mesenchymal stem cell. In here, our study, so we take mesenchymal stem cell isolation from bone marrow, and we culturing, and we take for passage 1 until and we become a single cell before ejected. And we make a niche with comparison normoxia and hypoxia. From GFU, normoxia is less more than hypoxia condition. And also expression for OX4 and SOC2, the expression from hypoxia in 3% concentration of oxygen. So there is an expression with immunocytochemistry. And there is a normoxian, no expression OX4 and SOX2. And also, as we know, P63 expression is becoming in the family of P53. There is a normoxian no expression, and hypoxia 3%, there is expression P63. So after that, we preparation for mesenchymal stem cell. And before injected, we validation with a pluripotency, contamination, and purity. And then we collaborated with eye clinician ophthalmologist. So after single cell, separate cell, so become under microscope, we injected to intraocular, intravitreal. And before that, we analyze from animal, so there is develop of retinal cell in the layer in animal eye. So the evaluation 3 months after injection, so 3 patients with retinopathy with anamnesis, blue revision, eye pain, and visual F 5/10 with autologous mesenchymal stem cell injected intravitreal. So we injected twice with a range 1 month. So from analysis become a brightness, decrease of pain, and the visual become 5/7.5. And 3 patients with retinopathic diabetic also with blue revision also and cannot read and cannot driving. With eye pain also, the visual is 1/60 with autologous mesenchymal stem cell intravitreal, which once injection, so decrease of pain, can read, short messenger, and can driving, and also the visual become 5/20. And 3 patients with retinitis pigmentosa with light perception only, so with autologous mesenchymal intravitreal for 3 times. They can read short messenger and converts the television, and the visuals become 3/60. But one of the patient left eye post injection twice, the patient find bubble in the vitreous, so we done a vitrectomy for the patient. So beside that, we also a clinical trial to many cases with from August 2014 we have 130 cases with many wild of many diseases in our department. So when it's sort of stem cell, usually we use autologous and less than allogenic stem cell, and we use a mesenchymal, NK cell, and nerve cell of neuron cell. So there is our center in Surabaya. Beautiful of Indonesia, maybe as beautiful as shown in on site. Thank you. Yes.
Can you ask you about the improvement in the sight? It was quite marked. And the improvement that you got in sight was really quite good, quite marked. And that was quite a big jump, I thought, from 5 to 7.5. So the patients must be very pleased with that sort of response.
Yes, the improvement is after 6-month injection. So we done not only one-time injection, but booster through until 3 times. With rinse for booster is 1 month.
Okay.
Yes. But some patient maybe because I don't know, because retinitis itself about the disease, so the vitreous is become not so clear. So we done a vitrectomy for the patient. After vitrectomy, the patient can visual with watching TV. Yes.
But they could all see in the end. I mean, the ones you showed us were all able to see with improvement.
Yes, improvement. All of improvement.
Mm.
Yes.
Okay, thank you.
Thank you.
Other questions?
Okay, thank you.
So I won't keep you long. I think we should, again, thank all of our speakers for today. It's been a very good day, and I hope the rest of the audience has as well. So thank you all for the speakers. And thank you, the audience. This has been a very engaging day, good questions and good interest, and those to the end, everyone appreciates it. I just wanted to make one more announcement besides the fact that there's refreshments outside the door there. The speakers who spoke today, there's a certificate for you. It's here. You can come and receive it now, or you can get it tomorrow. It'll still be here. So again, thank you all for a really great day. Certificates.